Good morning, everybody. I think we'll start in the next 30 seconds or something. We are bang on time with a good number of audience, both physically and virtually. We'll wait for 30 seconds more for everybody to come inside from the breakfast area. Till then, I take this opportunity to wish you all a very, very happy Ganesh Chaturthi, Michhami Dukram, and a whole lot of festivities that we are, experiencing together. And it's a nice time that we are able to do this physical conference all together, and looking at the response that we are having on a Sunday morning with the rains. We were all so worried that how will the people be coming to us, but the turnout seems to be very, very, overwhelming, that we have so many people, so many dignitaries. And it's with the blessings of Almighty, with the blessings of our parents, and with the support of Dr. Mona madam, who really, really pushed us, inspired us, and gave us this opportunity ke kai kariye chalo, and she made it happen. So thank you, ma'am. Thank you for that. And should we start? All right. So I welcome you all. Good morning. Namaste. I welcome you all to our second edition of Practical Diabetology. We came up with this concept that there are so many educational CMEs going on, but how about the practical implication when it comes to diabetes management? The pandemic of diabetes has increased so much that even on social medias, those who are non-medicos are, frequently posting about education related to diabetes and obesity and reversal of diabetes. So we thought, why not get the national and the international stalwarts together for our Ahmedabad population, for our doctors, for our healthcare professionals to learn more about the implication of diabetes. And I also take the opportunity to welcome our President, Dr. Kirit Kumar Ghadvi sir, Honorary Secretary, Dr. Dhiren Mehta sir, our Vice President, Dr. Maulik Sheth sir, and I invite you, Dr. Maulik sir, on the podium as the chairperson for our first session in hospital management of hyperglycemia. Sir is the Vice President of Ahmedabad Medical Association and Director of Creators Anesthesia Association. Along with him, we have a very, very dynamic personality, a very vibrant doctor and a family physician, Dr. Pragnesh Vashrajani sir, who is the past president of Ahmedabad Medical Association. Sir is always on the run and so active that he's an example for all of us, to lead a very, very active lifestyle. With that, I'm going to request Maulik sir and Pragnesh sir to take over the proceedings. Thank you.
Good morning, everyone. On behalf of Ahmedabad Medical Association and RIMS Institute, I welcome you all on this Dr. N.T. Shah scientific program today. As we all know, because of the current ongoing situation, this is a hybrid program, so we welcome our online viewers also. So without much ado, we'll straight away start with the scientific program, as we have got a galaxy of speakers waiting ahead to talk about various subjects. I will request Dr. Maulik Sheth to start with the proceedings.
Thank you, Pragnesh sir. Good morning, all. Welcome you on the behalf of Ahmedabad Medical Association and RIMS. So, without wasting time, I'm introducing the first speaker, Dr. Vipul Chawda. He has done his MBBS and MD from NHL Medical Group of College. Then he has done PG Diploma Diabetes Europe and PG Diploma Diabetes from RSSDI. He is Fellow Diabetes India. I had privilege to work with him in my residency at Shardaben Hospital. So welcome, Dr. Vipul.
Sir.
Good morning, all. Welcome to for one of its kind hybrid event of Ahmedabad Medical Association. And thank you so much, Chairperson, for kind introduction. So without wasting much time, let's start discuss about management of hyperglycemia in hospital setup. So why hyperglycemia is important? Because hyperglycemia occurs frequently in hospital patient and it affects patient's outcome in terms of it increases mortality, it increases inpatient complication, it increases the length of stay in the hospital, and overall hospital costs is increased because of in-hospital hyperglycemia. It occurs not only in patient who is non-diabetic, but also who are previously non-diabetic, they also have in-hospital hyperglycemia. This was a study which showed that 38% of patients who are admitted in hospital have some degree of hyperglycemia. So how can we classify this in hospital hyperglycemia? We can have first set of patients who are previously non-diabetic. Second set of patients are previously undiagnosed, but they are first time diagnosed diabetes after hospitalized, who have fasting more than 126, random sugar more than 200, and A1C more than 6.5. In second set of patients who are having stress hyperglycemia, who have the random sugar or fasting sugar high, but when we see their A1C, it is less than 5.7. So we have to diagnose whether the patient is already diabetic, first time detected diabetic, or patient is having stress hyperglycemia. Why to identify this hyperglycemia important? Because this was a paper from ACE that shows that when patient has sugar 100, 200, 300 and 400, we can see that 100 and 300 comparison, it increases mortality by 4-fold, and it is very high number. This is also one another paper that shows that in hospital hyperglycemia affects mortality, and it is independent factor that increases mortality in patient. So it is very clear that in hospital hyperglycemia clearly associated with increased morbidity as well as mortality, and we can or we have to do something to prevent this increased morbidity and mortality. So our own RSSDI, Research Society for Study in Diabetic in India, in 2016 thought that it should be prevented and we should increase awareness of in-hospital hyperglycemia, and they come out with guidelines for in-hospital hyperglycemia. And two of our speaker of today's event, Dr. Dhruvi Hasnani, who is present here physically, and Dr. Jimit Vadgama, who will come in after the next speaker, they are a writer or they are a part of these guidelines. So recommendations for in-hospital hyperglycemia, we can divide patient into 3 categories: critical ill patient, non-critical ill patient, and some special circumstances like perioperative condition, patient on enteral or parenteral nutrition, patient on steroidal therapy, CKD patient, transplant patient, and peripartum situations. So we can divide the therapy in 2 parts. We can give insulin recommendation or OAD, but I will talk about in hospital hyperglycemia critical ill patient, and I must say that when patient is critical or in ICU, OAD are not recommended. We should give either IV insulin, or when patient is stable and non-critical, we transfer this patient onto sub-Q insulin. Why insulin is preferred over OHA? Because insulin is not only sugar controlling drug, it is a hormone that is produced in the beta cell of the pancreas, and it has a pleiotropic effect. We observe in the COVID era that patients who were on insulin recovered very fast and had lesser complication as compared to patients who were on OHA. So our objective of treating this hyperglycemia is restore stable glycemic status, minimize the disruption of metabolic state, and minimize the adverse outcomes. This was a study that compared a sub-Q versus IV insulin, and those shows that IV insulin is better. How we should start the IV insulin? First of all, we should be noted that concentration should be standardized throughout the hospital. What happens that in hospital, many consultants are coming and going, and somebody is preferring 0.5 unit per ml, somebody is preferring 1 unit per ml, and this disruption create chaos in the medical officer who are there round the clock. So for any hospital, there should be standardized protocol that either 1 unit per ml or 5.5 unit per ml insulin should be given. Accurate bedside blood glucose monitoring should be done either 1 hourly or 2 hourly. And we must keep in mind that hypokalemia or hyperkalemia should not be there, because potassium interferes, insulin interferes with the potassium concentration. Now talking about the thing that monitoring capillary glucose should be done 1 hourly. Rate adjustment, consider the current and previous glucose level as well as current rate of infusion. Let's keep an example that we start in a new patient who has sugar of more than 400, and we start IV insulin 1 ml per ml, 1 unit per ml concentration at 4 ml per hour. Then we have to see this chart. It looks very complicated, but it is very simple. Let's see, we start at a 4 ml per hour, and after 1 hour we do the blood sugar, and that is 220. So now the sugar is 220 and blood sugar level has reduced. Is reduced less than 30 or it has reduced more than 30. So from 200 to 220, the blood glucose level is decreased more than 30 milligram per deciliter. So we should not change the rate of infusion. So we should continue the rate at the 4 itself. Now after 1 more hour, we check the blood sugar and it is 220. Now the blood glucose has decreased, but it has decreased less than 30. So now what we should do? We should see this column and we should increase the rate of infusion by 2 ml. So we should start it at a 6 ml per hour. And then after 1 hour, when we check the blood sugar, it is 170. So now the blood glucose level has reduced. It is reduced more than 30. So we should go in this column and we should do no changes. So it looks very complicated, but it is very accurate. Sometimes what happens, we reduce the glucose from 400 to 300 and we reduce the rate of infusion. It should not be there. At that time, we should increase the rate of infusion. So it is very important and we all should keep this chart in our ICU. What are the recommendations for limited care setting? Because all ICU are not empowered with infusion pump and everything. In that setup, we should take a 500 ml NS and pour either 25 unit of insulin or 15 unit of insulin according to the guidelines. If we want to give 1 ml per hour, then 50 unit, 0.5, then 25 units. So IV insulin should be transitioned to sub-Q or bolus insulin when the glucose level are very stable, patient is eating orally and there is no major changes in the schedule of the patient. Now, summarizing the thing, I must say that hyperglycemia common in critical ill patient both with or without diabetes, predictor of advanced outcome and including mortality. The significant improvements in the mortality and morbidity with intensive glucose management have been demonstrated, and some randomized control trials they have shown that we should use IV insulin when patient is very critical. We should not do very stringent blood glucose control like 80 to 110, but we should have a liberal control of 140 to 180 when patient is critically ill. And IV insulin infusion using a validated protocol to minimize hypoglycemia is preferred approach in a critical care setting. With that, I will end my talk. I welcome you all once again on the practical diabetology session 2, and thank you once again.
Thank you, Dr. Vipul, for your excellent talk for in-house management of hyperglycemia. I'm just handing over to mic to Dr. Pragnesh sir to introduce the second faculty.
Thank you, Dr. Vipul, for a very nice talk. It is time that we give up the system of Lal Pidu Lili, 4-8 bar 16 units. But still, I say a lot of indoor case paper with sliding scale of insulin. So it is time to give up and move on to the newer modalities of management. Now, I will welcome Dr. Rutul Gokulani for the next talk. Dr. Rutul will talk about non-ICU setting management of hyperglycemia. Dr. Rutul is a fellow, is a consultant diabetologist, is a fellow in diabetes from Liverpool, UK. He has done his postgraduate in diabetes from Czech Republic, Greece. He is a certified diabetologist from certified in diabetology from RSSDI and postgraduate in diabetes from UK. He is currently the managing director of Arogyam Healthcare Hospital and AHA Diacare Center. Of course, my neighbor, and visiting consultant at the Maudat Hospital, Paranpur. He has got a lot of publication and clinical studies to his credit. So I will welcome Rutul Gokulani for the talk. Dr. Rutul, please.
Thank you very much, Dr. Pragnesh, for wonderful introduction. And thank you very much, Dr. Vipul Chawda and Dr. Dhruvi Hasnani for organizing such a wonderful conference after so long. It's hybrid, but I feel like it is a physical meeting now as it is in AMA at our home ground. So today's my topic is on non-ICU settings, management of hyperglycemia. Dr. Vipul has beautifully explained all about ICU setting, and my job is a little bit easier than him, and hopefully I'll be able to justify after him. So what are the preferred regimens for insulins, especially because even in the non-ICU settings, what we prefer is the insulin. In some of the cases, when it is possible, we may prefer OADs or oral hypoglycemic agents, but in most of the cases, basal bolus insulin is the preferred option, though some of the hospitals, they prefer a premix insulin. Sometimes they prefer even sliding scale and incretin based therapy along with basal insulin. What is incretin based therapy? It is GLP-1 analogs or maybe DPP-4 inhibitors, and after that we may add basal insulin as well. So this is very busy slide and difficult to understand that estimating subcutaneous insulin dose for insulin naive patient or when IV insulin has been given according to total daily dose of subcutaneous insulin. So before that, I want to explain what are the basal bolus options. Usually when you see the prescription, it is glargine. Insulin glargine is the long-acting insulin. We have now available insulin glargine U300, which is ultra long-acting. Another option is insulin degludec. And some of the older molecules like NPH, they are also basal insulin, but they do not cover up whole 24 days. So usually we prefer glargine or insulin glargine U300 or nowadays degludec, insulin degludec as well. So basal insulin, we have 3 options, and bolus insulin we have 4 options. There is regular insulin. You all must be knowing about human ectrapid, that is regular insulin. This is one of the options for bolus insulin. Another insulin is glulysin, Lispro, and you know Novorapid, that is the aspart. And now we have ultra fast acting aspart as well. So we have ultra long acting basal insulin and ultra fast acting bolus insulin as well. So we have to calculate the dose according to those basal bolus regimens. And if the patient has ideal body weight, so we start with 0.5 to 0.5 unit per kg body weight. If patient is obese, then we start with 0.5 to 0.6 unit per kg body weight, usually 0.6 units per kg body weight. And if the patient is renal compromised, then we reduce the dose. We know that we have to reduce the dose as the chances of hypoglycemia are very high in renal patients. So in such cases, we prefer 0.3 to 0.4 unit per kg body weight. So according to this 0.3 and 0.4 or 0.5, it is a little bit difficult, but I'll explain you in very simple manner by an example. If a patient comes to you about around weight of 80 kg, then we give around, we calculate 40 units total of 0.5 unit per kg body weight, but we give 80% of that total daily dose, as patient should not land into hypoglycemia. So if we count 80%, then it is around 30 units. So what we do in this 30 units in non-ICU patients, that in this 30 units, we divide into 2 parts, 15 units of basal insulin and 15 units of bolus insulin. In this 15 units of bolus insulin, we divide further into 3 parts: before breakfast, before lunch, and before dinner. If patient is taking food by his mouth. So 5 units before breakfast, 5 units before lunch, and 5 units before dinner. And sometimes we have to give the correctional dose in some of the patient. So additional correction dose should be given according to correction factor, and that is maybe 1500. Some of the doctors count it by 1500 by total daily dose, that is 1500 by 30. Or in some of the patients, we count, some of the doctors count it by 1700 or 1800 by total daily dose. So in this patient, if we count it by 1500 by total daily dose, it comes around 50 units. So what does it mean? It means that by 1 unit, you are going to reduce 50 mg per dl whenever you give one dose, 1 unit. So if the patient's blood sugar is 250, we want to target 150. So we need to reduce 100 mg per dl. And for that, we have to give 2 units extra to that patient. So we'll not give 5 units, but we'll give 7 units. So this is very simple calculation, and we usually prefer such calculations in our practice. Sliding scale, already Dr. Pragnesh Vasrajani has said that we no more prefer sliding scale, though in some of the corporates still in ICU settings or non-ICU settings, they use it, but it is not recommendable and it is not effective as well. In a simple example, if I explain, if patient is taking food at 2 p.m. and we are giving insulin at 12, there is gap of 2 hours, and during this 2 hours, patient may land into hypoglycemia, and it is bigger concern in hospitalized patient, as patient may be case of sepsis, patient may be case of pancreatitis or renal compromised patient. So we do not prefer sliding scale insulin in most of the cases. Now, what are the options of oral hypoglycemic agents or non-insulin injectables? I already told that non-insulin injectables are GLP-1 analogs, though we do not prefer it that frequently, as they may cause nausea and vomiting. There is abdominal discomfort problems with GLP-1 analogs. But what are the oral hypoglycemic agents we can use in the simple patients who are very much stable? The selected patients may be candidate for continuation of previously prescribed OADs if they are stable in the hospital. Those who are clinically stable and eating meals and who have no contraindications. Conversion to basal bolus insulin regimen based on blood glucose result is better for management of hyperglycemia. So in stable patient, we may use oral hypoglycemic agents as well. And which OAD should be used? So first of all, we all use sulfonylureas, that is glimepiride, gliclazide or glipizide. But ideally, we should not use any kind of sulfonylurea which is long acting, because they may cause hypoglycemia for long run. And we may use short acting sulfonylureas like glipizide or gliclazide. Metformin can be used, but in very much stable patient. But we all know that they are contraindicated in the patients who are planned for surgery. They can't be used in the patients who are renal compromised, and also they may cause lactic acidosis as well. So metformin is better to be off, but in very stable patient, we may use or we may continue. TZDs, that is thiazolidinediones, that is pioglitazone, we all use in our practice. They also may be used in stable patient. But what happened with the pioglitazone, that we have to take care of patient's edema or volume overload, we have to look after. And the other thing is, patient may be case of underlying heart failure. In such cases, pioglitazone should be avoided. DPP-4 inhibitors, they are incretin based therapy. They are one of the safest molecule which can be used along with basal insulin. They act like bolus insulin. So we may use, but SGLT2 inhibitors, nowadays there are SGLT2s, especially dapagliflozin, which is available in the market at very lower cost. they are wonderful molecule, but they can't be used in a non-ICU care setting routinely because they may cause genital mycotic infections, as well as they have the chances of euglycemic ketoacidosis. So SGLT2 inhibitors also should not be used that frequently. If the patient is very stable, then you can use in some of the patient if the hospitalization is very short term. So for limited care settings, human insulins are better to be used than analogs. So because our nursing staffs are very much acquainted with those human insulins, that is human ectrapid. So with this, I would like to thank again to organizers, Dr. Vipul Chawda and Dr. Dhruvi Hasnani. And now who is next? I guess next is Dr. Bharat Sabu.
Thank you, Dr. Rutul. So now I am inviting one of the distinguished faculty all the way from Indore. He is joining online with us. So he is Chief Diabetologist and Director at Prayas Diabetes Center, Indore. He did post-graduation from School of Medicine, Boston University, USA. He has post-graduation training conducted by European Science Society of Endocrinology. He has various books published on his name. He has a special interest in artificial intelligence, and he enrolled with IIT Roorkee for a course in artificial intelligence and machine learning. So we welcome Dr. Bharat Sabu from Indore.
Thank you, sir. Good morning, everyone. Thank you for the nice introduction. And I am the only person, as Pradnesh sir really told, that I am hitting the target through satellite. So I'm really sorry to miss all my friends who are there, and I'm not able to meet them physically. I hope my voice is audible and my slides are visible to you all.
Yes.
Thank you, sir. So I would like to begin my talk, and I have been assigned a task of in-hospital management of hyperglycemia, keeping into view the special consideration of steroid and dialysis. So with a special thank and congratulations to my dear friends, Dr. Vipul Chawda and Dhruvi Hasnani, for pulling out this marvelous practical diabetology course. I will begin with steroids first, because we all know steroids are very commonly used in our day-to-day practice. And as far as I am concerned, most of the referrals which I get are from a orthopedic or a dermatologist friend who is seeking a favor of controlling the blood sugar values post the steroid induction. And in COVID, we have seen a surge in number of cases of steroid-induced hyperglycemia also. So we all know now the relationship between steroid and diabetes. They can be in the form of either a chronic use of steroid, which leads to diabetes, or a use of steroid in some patients with pre-existing diabetes. So in either of the situation, it is very important to achieve a good glycemic control, because to improve outcomes and prevent adverse event, it is very much required. Now, these are the all commercial preparations of steroid we all know are available, ranging from hydrocortisone, which has a duration of action of 8 hours, to dexamethasone, which was very commonly used, which has a half-life of 36 to 54 hours. So it makes our job a lot difficult. If we don't know what steroid is used, it is very difficult sometimes to treat. So it is always better to know what steroid regime is being used for the patient. Now, how the management is done. There are two subsets to it. In patients with no history of diabetes, when we start the steroid, we recommend blood glucose level measuring once daily, pre or post meal. My preference is a single post meal value. If the blood glucose value is less than 200 in post meal, a single reading, then the patient is labeled as low risk, and we should just record the blood glucose values daily post meal. If it is consistently less than 180, we should consider cessation of testing even, and we should consider that it is not affecting the blood glucose values. Now, if it is found to be greater than 200, then the frequency of testing is changed to a minimum 3 times a day. And this is very important, and the treatment should be done accordingly. Now, in known case of diabetes, if the blood glucose value is more than 200, the testing value should be, or the frequency should be minimum of 3 times a day, and treatment should be accordingly. Now, blood glucose usually rise within 4 to 8 hours after administration of oral steroids, and they rise little early with IV steroid. They can rise even at half hour. So the most common prescribed steroid is prednisolone in the morning, we all know, and it causes a rise of blood sugar levels by late morning. So the hyperglycemic management, what we need to do should be tailored according to the hyperglycemic need of the patient. Suppose in this patient, if we are giving a prednisolone, so we need to combat the daytime hyperglycemia. At the same time, because the effect will wane by evening, so patient can land up into a nocturnal hypo. So we should target only the hyper and we should avoid the hypos. Insulin therapy, that is why becomes a better option, an intermediate sort of insulin, intermediate acting insulin, NPH or Detamir, when administered with the steroid. At the same time, they may be able to best manage these sort of sporadic hyperglycemias. Now, the starting dose of NPH can be calculated as per the steroid equivalence dose, which is very simple to calculate. If we are using prednisolone or methylprednisolone and we are giving it every day, once daily dosing, so NPH 0.5 unit per mg should be given. Then if we are giving more than twice a day, then 0.5 unit per mg of glucocorticoid is divided into 2 doses and given. Or the routine dose of basal and bolus insulin should be increased to 130 or 140%. So a 30 to 40% rise in the total insulin dose. With dexamethasone, the things changes because it has a longer T-half. So NPH 3 unit per mg glucocorticoid equivalent is divided into 2 doses daily, and we use 40 to 50% of basal and bolus insulin. Hydrocortisone, when it is used once a day, we give a NPH of 0.125 unit per mg at the time of steroid. And if it is given twice a day, again the same dose of 0.125 twice a day at the time of steroid. So we increase the daily dose by 10 to 20% depending on the blood glucose values. Now, regarding the use of OHA in these patients, the patients who are on non-insulin therapy, so a single dose of short-acting sulfonylurea such as gliclazide for every 5 mg of prednisolone. This is a simple, very simple regime. 5 mg of prednisolone equivalent to 40 mg of gliclazide. That will save most of your patients. It should be taken before breakfast, and it manages the daytime surge in hyperglycemia and prevents the patient from hypo. If they are not controlled on OAD, then intermediate acting insulin, as I have told you with this substitution chart on the previous page, if it is continued late in the evening or overnight, then we can again add a dose of gliclazide or intermediate acting insulin. So the current evidence what we have, it doesn't support the use of DPP-4 inhibitors, GLP-1 analogs or SGLT2 inhibitor in the management of steroid-induced diabetes, because these therapies takes time to take place, and by that time the steroid takes its effect. So the patient who are on multiple hydrocortisone injection or dexamethasone or methylprednisolone pulse therapy, this is a special subset of patient when hyperglycemia is observed throughout the 24-hour period. So insulin therapy is what we usually recommend. A subcute insulin along with a basal or a multiple daily bolus doses is the treatment of choice. It can be given twice daily in a premixed form or a basal bolus, or both OHA and insulin can be given depending on the need of the patient. Now, if basal insulin, we should consider switching to morning administration and increase the dose to 2 to 4 units, because we are usually giving the steroid therapy in the morning first. So in acutely unwell patients, we always go by intravenous insulin infusion, and that is actually the treatment of choice recommended for the acutely unwell or critically ill patient, and it can be required for short duration. One more advantage of using a insulin infusion is, suppose you use an insulin infusion for just a 24-hour period, that will beautifully give you the total daily dose requirement of insulin. And that helps really, because then you can divide that dose into basal and bolus injection, and then you can control the sugar much better for the remaining days of the hospital stay. Now, tapering and discontinuation. So glucose level drops to normal in previously non-diabetic patients, as we have seen in COVID, within 24 hours after discontinuation of IV steroids in most of the cases. There may be some exceptions, but mostly it happens. And it may take several weeks in a dose-dependent manner if we are weaning the steroid over time. So the dose of anti-hyperglycemic agent, whatever we are using, we should taper accordingly, checking with blood sugar. A weekly reduction of 5 mg prednisolone, suppose we are doing. So again, the same dictum will follow. We will reduce the gliclazide by 40 mg. So this makes it very simple as far as steroid is concerned. Now the next talk which is with me is dialysis, how we deal with the effects of dialysis on blood sugar values. Because dialysis does a lot of effect on our body, it clears many glucoregulatory hormones as well, including insulin, glucagon, and C-peptides. So it can also affect insulin secretion. It can also affect insulin clearance and resistance due to the periodic improvement in uremia, acidosis, and phosphate metabolism, because the patient is usually in a seesaw sort of state when he is dialyzed and when he is not dialyzed. So glucose concentration in the dialysate also influences the glucose control, and that can also lower the chances of hyperglycemia and may even some cases cause hypoglycemia as well. It also affects the clearance of anti-diabetic therapy such as insulin or sulfonylurea. So all these things poses our patient to a higher risk of hypoglycemia. Now, what are our targets? We try to keep HbA1c above 7.5 to 8. This is our target because we want our patient to be safe and we don't want him to land into hypo. We keep a fasting target of 100 to 140 and PPG target of less than 200. We use blood glucose monitoring as the best glycemic control indicator along with HbA1c, fructosamine, and glycated albumin. But various studies have shown that SMBG is best. This is the first and foremost thing which we should see, because HbA1c is not a better indicator in our dialyzed patient. Now regarding diabetes management, out of OAD, if we still want to give OAD, glipizide, ripaglinide, and linagliptin, they are only safe medications in renal compromised patients, those who are on dialysis. So we can think about them, but the best choice is insulin. Insulin remains the treatment of choice, and we should always counsel our patient and attendant to be on insulin as far as dialyzed patient is concerned. We should always prefer a rapid-acting analog to reduce the risk of hypos in patients with EGFR less than 30. Basal insulin may or may not be required. I personally try to avoid basal insulin. Once end-stage renal disease is there, the doses of insulin, they come down. They are reduced to 50% of the previous dosage. SMBG becomes a must because we need to up titrate and down titrate the dose according to the need of the patient. And during hemodialysis, what we need to do during the period when the patient is going for hemodialysis, they should be encouraged to monitor and manage their diabetes by self-care. This is the utmost thing. They should bring their own insulin or tablet on the dialysis unit on the day of dialysis as well. The patient could lead into hypo. Blood sugar check should be checked pre-dialysis and just before finishing the dialysis. This should be a must. Blood sugar can fluctuate during dialysis and most frequently drops in the last hour of dialysis. This should be taken care of, and we should reduce the total insulin dose by 10 to 15% during and immediately following dialysis. A reduction in insulin dose is required in those with A1C less than 58 millimole per mole, that is 7.5, to avoid hypo. If our patient is having a tighter blood glucose control, then we should reduce the insulin dose prior to dialysis. Now, the blood glucose, if pre-dialysis, it is less than 7 millimole per liter, we should give 20 to 30 gram of carbohydrate prior to dialysis to prevent hypo. We should recheck blood glucose, and blood glucose monitoring just before finishing dialysis becomes a must. And he may require an immediate carbohydrate snack just after the dialysis. If the blood sugar value is 7 to 15 millimole per liter, no action is required. If it is 7 to 15 millimole just before finishing the dialysis, he is safe, no action is required. But if it is more than that, more than 15 millimole per liter, before finishing the dialysis, we should ask the patient to monitor blood glucose. We should ask him to be in contact and seek advice if the blood sugar values remain high. So patient, those who are on rapid acting insulin, they should reduce their usual breakfast if on morning dialysis. They should reduce the lunchtime snack if afternoon dialysis, or evening insulin if evening dialysis by 10 to 15%. This is must, and this is missed by most of the doctors I see. And on pre-mixed biphasic insulin, patients should reduce the dose by 10 to 15% with breakfast and with their evening meals. And on long-acting insulin, patients should reduce the dose by 25% in the morning or in the evening of dialysis. So peritoneal dialysis also comes into play because it is different from hemodialysis because it is continuous. Subcutaneous or intraperitoneal insulin injection is used. While we prefer subcutaneous insulin, the schedule is usually similar to hemodialysis. Now, what are the disadvantages of intraperitoneal insulin? It doesn't offer adequate control. It has a very complex schedule. The risk of bacterial infection increases because we are already on low immunity. If we are diabetic and going hemodialysis, we require a higher insulin dose. There is risk of peritoneal fibroblastic proliferation, which is always there. A risk of hepatic subcapsular steatosis is there, and insulin absorption varies or changes over time and differ between person to person. With that, I thank you all for your patient listening. Thank you.
Thank you, Dr. Sabu, for making the complex subject simple. Let me add, Dr. Sabu, that along with meeting your friends, you also missed the delicious bhajia that we had in breakfast today morning. I know.
Sir, I will soon be
have-
coming to you. I take your invitation for bhajia, and I will soon meet you, and we will have bhajias together.
Most welcome anytime, sir. Now we'll move on to the next talk. We have got a young rising star diabetologist from Surat, Dr. Jimit Vadgama. Dr. Jimit will be joining us online. Dr. Jimit is a consultant endocrine and diabetic metabolic physician at Surat, as I said. He is co-author for RSSDI guidelines for in-patient management of hyperglycemia in 2016. Executive editor, RSSDI textbook of diabetes, 4th edition. He has got in 2019 Rising Star Award from the Indian Academy of Diabetes. And he is also TYSA National Award winner in 2016, member of American Association of Clinical Endocrinologists, and former assistant professor of medicine at GMC Surat. I welcome Dr. Jimit for his talk.
Thank you so much, for the kind introduction. I hope I'm audible to everyone there. And first of all, let me congratulate Dr. Vipul and Dr. Dhruvi for this wonderful conference. And I'm really very sorry to not to be there. Let me also thank the previous speakers who have made my job easy. And I'll be speaking about few of the tips what we can get from the previous 3 sessions. So, is my slides visible? Can anyone confirm?
Yes, Dr. Jimit, they are.
Yeah, thank you. So, I'll be giving few of the tips from the practical experience what we have got since these guidelines were formulated. So, RSSDI, as Dr. Vipul has already mentioned, that recommendations for in-hospital management of hyperglycemia, these were published in 2016 under the leadership of Dr. Vijay Panikar, sir. Unfortunately, sir is unable to join us today. So I'll be speaking few of the tips here. And as Dr. Vipul has said, Dr. Dhruvi and I were part of this task force for development of this recommendation for in-hospital management. So 10 things you must remember, or these are the practical tips I would give. So very, very important things we are discussing from the beginning. Previous speakers have also, and chairpersons have also mentioned. We should avoid using sliding scale. So this is the number 1 tip that I want to give. And this is a very, very important thing because the evidences of in-hospital management has changed drastically. And we have now so much evidences that favors basal bolus treatment or personalized or individualized treatment in hospital patient as compared to sliding scale insulin. We all know it is very convenient to just write down a sliding scale to the patient's indoor sheet, but practically if you see, it can usually never achieve a good glycemic control. And this is the first and foremost tip that I want to give. And if you see the other tips, this again becomes the same. Please avoid using sliding scale. Please. So these are the 10 tips I want to give. But I won't bore you. We'll be discussing very, very important thing about the 10 important tips. We are very short of time. And let me give you the first thing. A few of the practical tips from the experience I have got during the formulation of the guidelines also. And during the practical experience since last 5-6 years, we are practicing this RSSDI guidelines. First and foremost thing, do not ignore any random blood sugar level more than 140. If a patient is admitted or even just before admission is unknown diabetic, you need to test it, track it, and treat it. This is the defect diabetes, this campaign this year going on, and always say no to this sentence. कि साहब 200 तक तो sugar चलता है. Patients have mentality 200 is normal, but never ignore any RBS above 140. And Dr. Vipul has mentioned that how we can classify the patients who have high hyperglycemia in hospital in 3 cases. So HbA1c is must for that case. HbA1c must be done in this admission. If it is not done in past 3 months, very important. It can help us classify the hyperglycemia of this patient. It is previously diagnosed case and he is previously undiagnosed. He is getting first time diagnosed during this admission, or it is a stress hyperglycemia. Dr. Vipul has already beautifully mentioned everything. And HbA1c, if you do in this admission, it helps us anticipating the degree of hyperglycemia that patient will go through in this admission. We can anticipate that patient will have very high sugar if his HbA1c, suppose it is 10, 11 or 12, that we might need to work very hard on this patient. Very importantly, HbA1c also helps us facilitate an optimal regimen at the time of discharge. If you do HbA1c, then you can take a decision that to continue the previous oral medication he is taking at the time of discharge. If the HbA1c high, you need to escalate the doses of treatment which patient was previously taking. And this is very important thing. Another questions I frequently get during the various meetings and webinars also. Sir, which IV insulin we should be using? Very important thing is which insulin protocol is less important than the actual presence of a protocol in that insulin, in that institute. Why important it is important? Because protocols, they change. There are so many protocols available right now, but just because there are multiple available and it is confusing or it is not practical, we are not using any IV infusion protocol. It is not that. We need to give all institutes a very individualized IV protocol, or very simply, you can use the RSSDI IV infusion protocol, which is very simple. So very important thing is, if you use RSSDI protocol or other protocol, it is very important to use a protocol in your ICU. That IV infusion requires a protocol. It is very easy. You can streamline it. And individual needs of that institute or that hospital needs to be taken care of. Suppose the patient has trained staff or associate, and they can go more aggressively. What are the resources available to the patient in the hospital, and how the communication to the primary consultant is going on. If the patient's blood sugar level are informed every hourly to the patient or not, we can individualize the need of that institute. Another important thing I want to highlight, please never ignore potassium level. It's a very important thing, and IV insulin has the highest and fastest efficacy of reducing serum potassium level, apart from hemodialysis. So give special attention to cardiac patients, because hypokalemia can many of the times then precipitate arrhythmias. And you must be knowing, in cardiac hospitals and post-procedure patients, immediate post-procedure patient for any cardiac intervention, potassium is monitored very well. And if you're giving IV infusion to your patient, it becomes very critical to monitor potassium, because they can end up in hypokalemia and can precipitate arrhythmias also. Similarly, potassium should be measured in CKD patients also, because via IV infusion, you can control that hyperkalemia going on in CKD patients. Very important thing. And diabetic ketoacidosis management again requires potassium supplementation, even at normal serum potassium levels. Always remember, the diabetic ketoacidosis, again, a huge topic to cover here, but it requires even potassium supplementation even at normal serum potassium levels. Very important thing. Fifth one I want to emphasize is, whenever you are switching from subcut to subcut insulin from IV insulin infusion, very important thing, you need to give subcut insulin in advance. Suppose patient is in the ICU on IV insulin drip, and you are shifting them to subcutaneous basal bolus treatment, please give subcutaneous insulin in advance, little bit of advance. Why? Because the half-life of IV insulin is very less than 5 minutes only. And if you stop IV insulin and you give your next bolus when the patient is eating after a few hours, you will have recurrence of hyperglycemia. And it is very important for regular or rapid-acting insulin. which you are giving subcutaneously, continue infusion 1 to 2 hours after the first subcutaneous insulin dose. And if you're giving a basal insulin, long-acting insulin, give the or the continue the infusion 2 to 3 hours after you have given the basal dose. This is very, very important. Otherwise, you will end up in hyperglycemia again. Another practical tip is patients who are on basal bolus treatment. Okay? And Dr. Rutul has mentioned that we need to test the pre-meal sugar and we need to give bolus is there. So what I want to highlight is please test the sugar level as near to meal as possible, just before the meal if possible. And it should not be checked 1 hour before the meal. This is very important thing because of the nursing staff habits, because they have given the task, or they were given in the over that you have to check the fasting blood sugar of this patient and you need to inform the doctor. What happens? Their shift is changing. They do the FBS, fasting blood sugar level, early 6 a.m. and you will be informed that your patient's fasting blood sugar level is this much. At the breakfast is coming at 9 a.m. So this is a huge gap. So always test the blood sugar level as close to meal as possible. This is a very, very practical thing you need to understand. The main point is avoiding sliding scale. Why? Because sliding scale is it is like an administration of pre-established amount of short-acting insulin in response to hyperglycemia. There is no relation to meal timing and no relation to the carbohydrate content of the meal, what the patient is going to eat and when the patient is going to eat. There is no relation to insulin dose in sliding scale insulin. And if you use sliding scale as a sole regimen for management of hyperglycemia, it is ineffective. Okay? Dr. Rutul has also mentioned that it is ineffective. And very high chances of severe hyperglycemia and hypoglycemia if you use sliding scale insulin. That is not recommended by any guidelines. And as I said, there are numerous evidences and even randomized controlled trials available right now which supports basal bolus insulin or individualized treatment, and they strongly denied using sliding scale in hospital. And very important thing, why we want to give the basic of using basal bolus insulin regimen is basal insulin is required to inhibit the hepatic gluconeogenesis. Very important thing. While bolus or nutritional insulin, which we give pre-meal before eating, is required to facilitate the mealtime glucose metabolism. Whatever the carbohydrate we ingest, boluses are required for that. And sometimes we use correctional insulin also, which Dr. Rutul has mentioned, is provide real-time adjustment of insulin dosing. Eighth thing I want to, very, very practical tip about hypoglycemia. Okay. And we should always avoid overcorrecting hypoglycemia. What is happening is whenever you get a call from the hospital that, sir, the patient's sugar level is 65, and you on phone only you advise the same old advice कि 50% dextrose water का एक pint दे दो उसको जल्दी से. This is a usual advice, but it is not the best advice to give. Why? Because whenever you give such high load of dextrose to the patient when the sugar level is low, we see a seesaw effect. What is seesaw? Means once you give a dextrose, the patient blood sugar level will again rise 200, 300, 400 also sometimes. And sometimes you have to give again insulin to correct that hyperglycemia caused by that 50% dextrose. Sometimes what happens in few of the elderly patients or susceptible patient, if you give 50% dextrose, that is very concentrated and high osmolarity, it has chances of thrombosis of IV cannula or the vein thrombosis also. Many of the times, many doctors, they prefer 25% dextrose water. And whenever you are giving this dextrose, always try to count the amount of dextrose to be given according to the patient's blood glucose level at present during the hypoglycemia. So this is a simple example. This is a Jocelyn formula you can use. You can take a screenshot, very simple, that patient's blood sugar level you remove from 100 and multiply it by 0.8. And it will give you the how many mLs of 25% dextrose water should be given to the patient for correction of hypoglycemia. Very important thing, suppose patient blood sugar level is 50 only, and you want to calculate how many ml of 25% dextrose you want to give. So it is important. So blood sugar level is 50, 100 minus 50 is 50, and you multiply it by 0.8. So you have to give 40 ml of 25% dextrose patient for that correction. And never forget to pre-check after 15 minutes, because many of the patients are on longer acting sulfonylureas or basal insulin, and they have a tendency to go again into hypoglycemia. So this is a very, very simple formula, and you can avoid the seesaw effect or the rebound hyperglycemia after giving a big pint of 50% dextrose. Very important thing, whenever you are planning discharge medications, I see majority of times the surgeons or many hospitals also, or the specialized hospitals where the diabetologist is not attached, or where what happens, the patient is advised to take their previous medications and continue post discharge. But this is not true. Patient ne કહી દેવાનું કે તમે જૂની દવા લેતા હતા એ ચાલુ રાખો discharge. But this is not the best way. Always try to adjust the medication of this on discharge according to the previous HbA1c. Is well, then you can continue the same oral tablets. If there is no new indication or contraindication, change the medication according to past history and comorbidities, because patient has come to you. This is an opportunity. You can modify the treatment and look into consideration about the new indication and new contraindication during this admission. Suppose a patient is on a heart failure and you want to minimize the heart failure risk. There is now a new indication for heart failure. You can add an SGLT2 inhibitor or remove the contraindicated drugs like pioglitazone during this admission. It's a kind of simple thing that you need to understand during discharge planning of medicine. Very, very important thing. And extremely important and last thing, and always forgotten thing, is whenever patient is getting discharged, before the discharge of patient, whenever you are last visiting your patient, please emphasize on lifestyle changes, right? Because it is a time and when the iron is hot, and you need to strike at that time only, and patient is more susceptible to your lifestyle changes advice you have given to them. Suppose a patient is having just an acute MI, you will tell them you need to follow this diet, you need to regularly do exercise, you need for regular follow-up. And if you give this advice at that point of time, is very, very effective and effective for long time. I thank you everyone for listening to me. I'm sure I have completed in time, and we have a question answer session going on next.
Session concluded, and the session is open for any question answers.
તમે નહીં પૂછો તો હું પૂછી લઉં. We are going to ask a question after every session, and a person who answers right is going to get the prize at the end of the full day program. So the question for this session is, for a in-hospital diabetes patient, what should be our target for sugar control? Option 1, 100 to 140. Option 2, 120 to 180. Option 3, 140 to 180. And option 4, 150 to 200. Please raise your hand. Don't answer straight away. There are 2, 3, 4, 5. Pellu Kariu Sahib. Yes, sir, please. Come here. Yes. Sorry? Okay. Biju sir Kariu Sahib. Bolo. Yes, please. Red shirt, please. Yes.
Yeah.
I think he's right. Thank you.
Thank you. Vaishali, can you have his name and number? We will give him the prize at the end of the whole day session.
Thank you.
Thank you so much, chairpersons and all our dignitaries and all the faculty joining us online. I would request Dr. Abhay Dikshit sir to please present a memento to our Vice President AMA, Dr. Maulik Sheth sir. Can I have the memento, please, Urvashi? Abhay Dikshit sir is the president of AFPI, the Association of Family Physicians of India now. So from one president to one vice president, we have the honor of having the blessings of so many people today. Incoming president. All right. Thank you so much, Maulik sir. Thank you so much for chairing our sessions. Can I request Dr. Imtiaz Vora sir, who is, the Chief Superintendent for Kheda Civil Hospital, to present a moment to our chairperson, Dr. Pragnesh Vachrajani sir. Urvashi? Thank you so much, Pragnesh sir. And now, can I request Dr. Maulik sir and Dr. Pragnesh sir to present a moment to our faculty, Dr. Rutul Goklani, who's been always kind enough to be present at all our practical diabetology sessions, both online and offline. Thank you, Rutul. Thank you. We are a very, we are a huge team of diabetologists from across Gujarat and India. The sessions which we are having today are available both online on YouTube as well as on our Facebook platform of Rudraksha Institute of Medical Sciences and on RX events as well. So you can join our sessions later on to listen to all our esteemed faculties. I would like to mention a great thank you to Dr. Bharat Sabu sir and Dr. Jimit Vadgama sir. We'll be sending you, sir, your memento soon to both Surat and Indore, and we wish that we have the pleasure of having your presence in Ahmedabad soon. If you can hear me, I am not sure.
Dr. Dhruvi, we will be coming here to collect it. Keep it with you. That would be motivation to come to Ahmedabad.
Absolutely, sir. We look forward to having you. With that, we move on to our next session on women and endocrinology. And to chair these sessions, can I request Dr. Sheetal Deshmukh ma'am? She's a leading OBGYN from Khokra and from the team of SNE Hospital. She's a very, very dynamic person. And I feel that I was the only workaholic female, working. And then I saw her and I'm like, oh my God, you work on Sundays. I'm like, so awesome. Ma'am, welcome to chair the session. Our second chairperson is Dr. Deepak Rao sir. He is an oncosurgeon and a very well-known dignitary in the circle of Ahmedabad Medical Association. With that, I'm going to stop talking and give off the stage to you, sir.
Good morning, all. Moving on to our second session after the very to the point discussion about inpatient management of diabetes. Our topic for the second session is women and endocrinology. Before that, I would like to welcome our president for IMA GSP, Dr. Devendra R. Patel, who is here. So moving on to our second session, the first topic is by our own Dr. Nisarg Dharaiya. He is a very dynamic member of our association, and we will talk on PCOD. Dr. Nisarg Dharaiya is a MD in obstetric and gynecology and very well known in the Ahmedabad Medical Circle. He is the director and chairman of SNE Hospital and IVF Center. He has worked as a faculty at Advanced Infertility and Laparoscopic Gynecology Department at IKDRC Civil Hospital. He has performed about 300 independent diagnostic laparoscopy, and he has received Asia's Greatest Brand of 2017 by the PricewaterhouseCoopers for the category of Asia's Greatest 100 Brands of the Year. The Best Women's Hospital and IVF Center in Ahmedabad, Gujarat by Golden Star Healthcare Awards 2018. Best Male Infertility Specialist in IVF Center of Ahmedabad by the India Healthcare Awards. He has attended various conferences as chairpersons, and I would like to welcome Dr. Nisarg Dharaiya now for his talk on PCOD.
Good morning, everyone. First of all, I would like to thank all of you to attend this prestigious session and specifically REAMS teams to allow us this opportunity. Without wasting much time, let me start our today's topic, which is related to an association between gynec point of view, woman's prospect and diabetes problem, which is a very common problem nowadays. We came across in so many adolescent girls and women, and then after it leads to woman related so many reproductive and obesity related issues. So today we are going to discuss a topic of PCOS, which is called as PCOD also. Polycystic ovarian syndrome or polycystic ovarian disease is one of the most common endocrinopathy affecting women. It has an unknown etiology and it is recognized as a heterogeneous disorder that results in overproduction of androgens. So primarily it arises from the ovary and is associated with later on insulin resistance. So on this basis, we have to understand that whenever we are going to treat this disease, we have to definitely correlate medicine branch or endocrinologist to correct insulin resistance and androgen related overproduction. Main epidemiology, in brief, we can understand it is the most common endocrinological disorder among the women between age of 18 to 44 years. PCOS is, we can say that PCOS is present if any two out of these criteria are met in the absence of other causes of or for these findings. One, by eliciting history, if we found that ovulation or anovulation cycles are there. Another thing, excess androgen activity. And third is almost considered as a benchmark criteria is polycystic ovary picture is seen in ultrasound findings. These are the Rotterdam's criteria, which has mentioned that if any woman is having these two positive findings out of these three factors, she will be tagged under PCOS cases. To understand briefly, if we go through the ovarian picture, so in normal ovary we have only few follicles, while in the PCOD ovary, polycystic ovary, there will be a multiple follicle of small size, which will prevent normal ovulation, and due to this anovulation and oligomenorrhea or disturbed menstrual cycle patterns, and which will result later on in infertility and all these subsequent woman hormonal related issues. So these are the symptoms sometimes we might seen in so many adolescent girls and women, but we even as a practitioner have not noticed. We might have seen some family members or some nearby friend circle, but we might not notice. So just by observing, we can have that excess body hair growth, weight changes and trouble losing weight, ovarian cyst in sonography, then low sex drive, irregular or missed period, male pattern baldness and thinnings of hair, high estrogen levels and blood reports, insulin resistance, complaint of fatigue, acne comparison, persistent acne might be there mood changes, and trouble conceiving in pregnancy, which is called infertility. How can we diagnose this disease? So by initiating history, we should ask a menstrual pattern, change in the weight towards obesity. So sudden weight gain or not able to lose the weight might be an associated pickup point. Hirsutism, acne, fertility issues, family history of hormone changes including diabetes. These might be, we can initiate from medical history. Physical examination by checking, so generally it is associated with thyroid abnormality, skin changes and hair growth. We can also have BMI check and pelvic examination for USG checking for enlarged ovaries. The confirmed diagnosis we can have through ultrasound examination. Pelvic ultrasound may show enlarged ovary with multiple small cysts. More than 12 follicles should be seen in the ovarian ultrasound examination. The follicle may be oriented in a peripheral, giving an appearance of string of pearls. It will be in a external surface of the ovary. Laboratory test which concludes that due to irregular menses, first we should exclude that pregnancy is not there. Then testosterone, prolactin, cholesterol, triglyceride, TSH, then adrenal gland hormones, GTT, and elevated LH. LH would be higher because of its insulin resistance and male pattern thing. So LH would be higher in comparison to FSH ratio in PCOS cases. So this is what a difference we can easily initiate in a sonography picture. In PCOS, we will have multiple small follicles situated in the periphery of the ovary, and in normal ovary there would be one bigger follicle which might later on ovulate in this cycle. So in normal ovary we can have 6, 7 to up to 10 follicles, and in PCOD we will have more than 12 follicles. How obesity, PCOS and infertility is associated? So obesity has substantial effect on manifestation of PCOS. 35 to 50% women with PCOS are obese. 50% of overweight women will have PCOS. Obesity plays a significant role, not only determining the severity and clinical manifestations and metabolic disorder. Significant increase in infertility and menstrual irregularities has seen the female who is having BMI more than 30. So obesity augments the metabolic disorder and prevalent in PCOS, leading to irregular menses, oligomenorrhea, chronic anovulation, lower pregnancy rate, higher miscarriage rates, and increased obstetrics complications. Obesity may have a marked impact on both development and progression of PCOS. That is very obvious. And PCOS is not only a reproductive disorder, but also associated with significant increase in metabolic abbreviation and cardiovascular risk factors. As the disease progresses, obesity progresses, and associated all the disease related to obesity, diabetes will be take place later in a later life. Reproductive symptoms of PCOS are generally anovulation, subfertility, and hyperandrogenism. Associated symptoms are acne, obesity, baldness, menstrual cramps, oily skin, excessive hair growth, deepening of voice, male pattern voice, heavier menstrual cycle, increased risk of chronic illness. This is a very surprising study. Indian Journal of Pediatrics has published in 2020 that prevalence of PCOD in India, 30 to 36% girls in India are suffering from PCOS. It's a very huge number, and rather than giving medicine and treating through a surgical intervention or treating the complication, my today's topic, I would like to focus on how to prevent, because this is a huge number. You cannot treat 40%, 36% of girls simultaneously of whole India. So by focusing on management, medications and surgical treatments are anyways possible later on when we have a patient with disease. But our main goal should how to avoid and how to modify our lifestyle and guide a patient so that we can have prevention of this treatment, and we, without medicine or without complication, we treat the patient. So first is regular exercise, healthy diet, weight control, try to quit smoking. Our medications are definitely metformin, oral contraceptive pills, and some others. Surgical treatments are ovarian wedge resection, so and laparoscopic ovarian drilling. So whatever extra follicles are there, we can remove through laparoscopy and reduce the androgen excess. Lifestyle changes, which is considered as a in form of diet, exercise, weight loss, behavior changes, and smoking cessation. One thing we have to understand, when we are going like COVID like disease or PCOD like disease, which is spread in a huge manner, that it is always come under multidisciplinary approach. Only gynecologists cannot deal with it, or only endocrinologists cannot deal. It's a multidisciplinary approach where clinician, dietitian, gym instructor, exercise specialty, and counselor all takes place, and even family members should counsel in a manner that it's a very a prevalent disease in which you should support a adolescent girl in terms of having proper family support, rather than saying you are obese and you are taking junk food and all these things. Rather than, you should counsel in a way that she accept a change in her lifestyle, then and then we can deal with this disease in a multidisciplinary approach. So first is diet. Cut down the calories, especially in the evening. It is generally recommended that the spread of the calorie throughout the day by having 5 to 6 small meals. This will reduce cravings for sweet and starch, which is very common among women with PCOS. Favors monounsaturated fats, nuts, fight insulin resistance associated with PCOS. Choose low GI carbs. Low GI carbs, which have much longer time to digest, cause only a small and slow rise of blood glucose and insulin level. In addition, low GI foods reduce craving as they provide the body with a slow, steady supply of energy. Load on vitamin, all type of vitamin B. B in sunflower seeds can help to beat PCOS symptoms like vitamin B12, B3, B5, B6. In addition, B2, B3, and B6 are essential for normal thyroid function and metabolism, and thus help in reducing excess body weights. So definitely they are supplements, but it has adjuvant role. Ensure a sufficient intake of calcium and vitamin D. Calcium plays an important role in egg maturation and follicle development in the ovary. So we have to put focus on calcium, and vitamin D is an essential for promoting calcium absorption from the food in the intestine. Zinc rich food is necessary. Beneficial effects on at least 2 common conditions associated with PCOS, which is called acne and obesity. There's direct indirect effect of zinc has observed in reduction of these 2 symptoms. Eat plenty of foods that contain magnesium. Research indicates that there is a strong link between magnesium deficiency and insulin resistance associated with PCOS. Magnesium appears to be the most common micronutrients found to be depleted in insulin resistance people and diabetic patients. Effect of weight loss. See, we generally do not consider, but even motivation might help. Only 5% loss of body weight will reduce insulin resistance and circulating androgens, resulting in spontaneous ovulation and relief of symptoms. So even if minor,
We should finish within
Sure.
1-2 minutes.
Okay.
Been getting indications from the.
sure. So weight reduction is a very important role. Treatment focus should reduce insulin resistance, improve metabolic features, improve reproductive function, and improve body image and mood. We should counsel a patient to start at least from somewhere, whichever activity she likes. Like exercise should be as a motivation factor, not as a punishment, and she should be encouraged and challenged to do regular exercise. Some exercises she can plan at home, that is called treadmill and bicycle, or something like aerobic training, something at gym like dumbbell and weight pulling machines. HIIT, that is called high intensity interval training exercises, which has very good result and long effect on calorie burn. So workout will have very good impact on that. The last modality which is considered as a prevention is yoga. Yoga has very good effect in hormonal imbalance control. This is one cobbler's pose, which is very useful in PCOD patients. And one is that moon's salutation. These are the yogas which are helpful in this thing. Another medications and surgical interventions are definitely there, but that will be taken care by expert gynec team or endocrinologist. So whenever we are discussing these diseases, a generalized prevention manner, these are the primary management. The conclusion is obesity and sedentary lifestyle and PCOS associated with anovulation and failure in infertility treatment. Lifestyle modification, weight loss and exercise prior to infertility improves ovulation rate and reduces the symptoms a lot. The best diet and exercise regimen are unknown, but calorie restriction, increased physical activities are recommended. The ideal amount of weight loss is unknown, but 5% decrease will be, even 5% will be very meaningful. Thank you.
Thank you, sir, Dr. Nisak Bhai, for such a nice talk on the topic of PCOS, which is, I think, is a very common problem nowadays in our society. Thank you very much. I now will hand over mic to Dr. Sheetal for inviting next speaker.
Thank you. So our next speaker is Dr. Sunil Gupta. He will be joining us online today. He is a diabetologist, MD, CEO of Sunil's Diabetic Care and Research Center Private Limited, Nagpur. He has published 196 articles, book chapters and abstracts, presentation in the national and international journals. He is a receiver of many awards, including only diabetologist of a country honored by Outstanding Young Person of the World 2002 award, Ranjit Deshmukh Central Indian Doctors Award in 2015, National Award for Best Diabetes Education 2017, Vaidyakiya Shiromani Award 2015, Young Achievers Award 2013, 10 Outstanding Young Indian Award 2001, and his name is included in Guinness Book of World Record 2013 and in Limca Book of World Record 2016. He was a national executive member 2016 to 2019. He was former zone chairman of IMA, AMS, President Diabetic Association of the India, Nagpur 2000 to 2001, Academy of Media, Medical Science 2010 to 2011, and former chairman of IMA, AMS, Nagpur. Over to you, sir.
Yeah. Good morning, everyone. And hope I am audible to everyone there. Okay. Do we have Shruti around? Dhruvi, I'm sorry. Do we have Dhruvi around?
Yes, sir. Yes, sir.
Dhruvi, you have asked me to be there for 10 minutes. So I'm there for 10 minutes for you.
Thank you so much.
Now, I have seen my slot and I thought it will be injustice if I speak on slides. So people have already heard me many times. Let us have some discussion and conversation with each other on this topic of hyperglycemia and pregnancy. I feel that will justify my position to be there as a DIPSI president. Because if I speak, then I'll be unnecessarily spending around 8 to 9 minutes, and then at the end you will say we had short of time, so better not to have any question answer session. So let us have it as a 10 minutes open session. It will possibly also help you to reduce the monotonicity of of the whole CME. So let us have some discussion on hyperglycemia pregnancy. To start the introduction part, let me tell you that our country is having quite a high number of gestational diabetes. Every sixth pregnancy in the ANC clinic may be having the hyperglycemic pregnancy. Out of them, almost 85%, or maybe in India, maybe 90% of them may be pure gestational diabetes, which usually appears in pregnancy and disappears after delivery. But 10% may be pre-gestational diabetes, who might be having either pre-existing type 1 diabetes, it might be having pre-existing type 2 diabetes, and they are now planning for pregnancy. And few of them will be coming to you for the first time in the ANC clinic, but they have never checked their blood glucose, and they have hidden type 1 or type 2 diabetes, more likely to be type 2 than type 1 diabetes. And these individuals become big challenge to you when they come to you at 12 weeks, 14 weeks of pregnancy with HbA1c of 9, 10, 11, and sometimes even more than that. And you are already, the organogenesis part is already over. You know, we should know that organogenesis is over by 6 to 8 weeks of pregnancy. Any hyperglycemia, any high blood glucose in this period might become teratogenic to the baby, and you might have a risk of congenital malformation or the missed abortion, up to ranging from maybe 2 to 3% or 5% to up to 25%, depending on the baseline HbA1c at the time of conception. So, so this is about pregestational diabetes, which is now being classified as diabetes in pregnancy, where you have both type 1, type 2 who are becoming type 1, type 2 diabetic, becoming pregnant, or the other patients who are being diagnosed for the first time. So with this introduction of pregestational diabetes, which is called as DIP, and gestational diabetes typically appearing in the second and the third trimester, usually after 20 weeks, sometimes 24 weeks of gestation. Out of them, 90% disappears, maybe 10% may persist after delivery. So this introduction, let us have Dhruvi some conversation on these lines. I know you must not have prepared any question because I have never not told you. But if you remember, our discussion was that 10 minutes you be with us. So I'm there, and it will help in, if someone has some questions, you can just fire on me. If possible, I'll try to justify. If not possible, I'll say sorry and I'll come back next time to solve that issue. I feel you're not audible. You're not audible here. Yeah.
I think that cannot be possible, sir. You are one of the leading faculties for Diabetes and Pregnancy Study Group of India, and congratulations, sir, for being the president. Thank you, sir. Thank you for joining us so much. If we have any questions from the audience related to diabetes and pregnancy, hyperglycemia and pregnancy, we have one of the most outstanding faculties who can answer all our queries today. And you know, we can take up any questions today. Yes, sir.
I feel you'll have to repeat the question, or I'm unable to hear. Can you be, doctor, can you be little louder? Doctor, can you be little louder?
I'll repeat the question, sir.
Yeah.
If blood sugar level is more than 140 during the third trimester, what is the management at that time?
In the first trimester, you mean to say?
Third trimester, if the blood sugar is more than 140, sir, what should be our line of management?
Yes, so that's a cutoff point of diagnosis of gestational diabetes. If you give 75 gram glucose, there are DIPSI guidelines, Government of India guidelines, that any woman who is being presented to you for the first time in the ANC clinic, irrespective of the weeks of pregnancy, whether she is fasting or non-fasting, give 75 gram of glucose in 200 ml of water to be taken in 5 minutes period, take blood glucose after 2 hours. And these 2 hours, she should not be walking, she should not be exercising, she should not be going to the mall for having shopping, she should be sitting in the clinic, and she should not smoke. So these are the basic rules. And if suppose you after 2 hours, your blood glucose is more than 140, then we diagnose it as gestational diabetes. When it crosses 200, we diagnose it as pre-gestational diabetes, maybe diabetes in pregnancy, which is a criteria in non-pregnant state. So 140, more than 140 GDM, especially typical case of GDM in third trimester if you diagnose it.
And so what should be, for simplification purpose, what should be our first choice as a management if, for example, the lady's coming to us, we did the DIPSI criteria, we did the OGTT, and say the blood sugar comes to 140, like our sir is asking, what should be a first line of treatment?
See, Dhruvi, the first line, Government of India has approved metformin as a first line. First is, of course, medical nutrition therapy. Wait for 2 weeks. If it is a case like very simple case, doctor has asked, I feel this is what I expect from our discussion. A simple case, more 150 blood sugar आ गया, अभी क्या करना है? अभी अपने को पहले 2 weeks तक के you have to give medical nutrition therapy. In between these 2 weeks, you go on monitoring blood glucose maybe every 3rd day, 4th day, fasting, post breakfast, post lunch, post dinner. Your target is fasting should be less than 90. 2 hour post meal should be less than 120. If you achieve the target of 90 and 120, fasting 90, postprandial 2 hours, post breakfast, post lunch, as well as post dinner, if they are less than 120, your medical nutrition therapy has worked. Continue medical nutrition therapy. But in 2 weeks, if you fail to achieve these targets, then metformin can be the choice, provided patient does not have any evidence of placental insufficiency. If some baby is in intrauterine IUGR, if suppose someone is suspected to have a low birth weight or intrauterine growth retardation, in that situation, metformin is contraindicated. Someone has preeclampsia, it is contraindicated. Someone had bad obstetric history in the past, it is better we avoid and give insulin. Insulin is a best drug. It is a drug of choice globally. But in less resourceful situation, where patient doesn't want to take insulin, metformin can be given. The only hitch we always have, or hiccups we always have while prescribing metformin, is that metformin crosses the placenta. And to a large extent, up to 50 to 70% of the maternal level, the same level there in the fetal circulation. And that is why one should remember that it is the metformin crosses the placenta, but insulin doesn't cross the placenta. And that's the beauty of insulin therapy. That's why we say insulin is safest, but metformin is not contraindicated. Fortunately, you have Government of India guidelines to protect us from any rarest of rare complications of metformin.
Thank you, sir. Our very
Good morning,
esteemed
Sunil sir.
faculty.
Dr. Vipul here. Thank you so
Yeah,
much, sir.
Vipul, good morning to you, beta. Bolo,
Yes,
bolo.
thank you so much for accepting invitation and being here. I have Dr. Vinod Abhichandani, sir, who is very senior consultant of Ahmedabad.
Yes. Very close knit we have. Dr. Abhichandani, good morning to you. It's nice to see you in the hybrid meeting. So nice of you after a long time.
Very good morning, and it's a privilege to listen to you as always, real master of the subject. Now, I believe our DIPSI has few recommendations that screen at the first contact a lady for sugars. Again, repeat 75 gram oral GTT between 24 to 28 weeks. Even if that is negative, we are allowed to repeat between 32 to 34th week of gestation. So what comments do you reserve as an expert for the third screening, that delayed screening? I personally, in my humble practice, I do that, but I would like to listen to your expert comments regarding.
See, Dr. Abhichandani, one should know that in India, Indians, women are at 11 times higher risk to have hyperglycemia in pregnancy or gestational diabetes. And that is why it makes sense that we try to explore that possibility, rare possibility, because most of the GDM women globally, they are being diagnosed in the 2nd and the 3rd trimester, usually after 20 weeks and 24 weeks to be more precise. But in India, we have seen that almost 20% are being diagnosed in the 1st trimester. And there is one data which says before 20 weeks, almost you will have 70% of the GDM are diagnosed. So you are very true that in the first 20 weeks, many of them may be diagnosed. 24 to 28, yes, you have an opportunity to diagnose, but we should not miss out even the last trimester. So we say minimum 2, but maximum 3 screenings. If you miss out, yes.
Thank you very much for that explanation.
Thank you.
Yes, sir. We have Urman Dhruv, sir. Sunil sir, you may know Urman sir very, very
Yes,
well.
I know very well. Dr. Urman, good morning to you.
Good morning. Dr. Gupta, looking to the safety of glibenclamide in few of the trials, do you think at the level of DIPSI, can we go for ethical trials of glibenclamide in third trimester? Is it
Yes.
advisable?
Yeah, I feel this is a very valid question. Globally, glibenclamide has been approved by most of the organizations except DIPSI, but also that we don't have a long-term safety data, Dr. Dhruv, as far as this is the glibenclamide is concerned. Now we are getting more and more data of metformin. We have the MIG tofu trial. MIG tofu trial, they have done the trial where they have actually seen the long-term follow-up of offspring of diabetic mother who were given metformin versus insulin. They have that data up to 7 to 9 years. And yesterday I had a meeting with the HAPO group also. So even HAPO group is again taking a follow-up this year, 2021-22, which is of the 12 to 14 years of age. So we have got long-term follow-up of metformin. We certainly have long-term follow-up of insulin along with metformin. But unfortunately, we don't have a long-term follow-up of the glibenclamide globally. It is only South Africa, Oded Langer, who has done wonderful work, and his data is published and he always promotes metformin. And let me also share, Dr. Dhruv, you are very correct. The highest prescribed oral drug in pregnancy in US is not metformin. It is glibenclamide. It is glibenclamide. But unfortunately, we don't have any Indian data and we don't have any safety data available for long-term follow-up. That is why we are a little worried about. And that's why Government of India and experts of DIPSI have not yet started writing. And we know the disadvantage of the potency of glibenclamide, which could be in long-term maybe, unless until we have safety data available, we have kept a pause for glibenclamide.
Thank you, sir. Thank you. Dhiren sir wanted to ask something. Thank you, sir. We'll take one more question, Sunil sir, if time permits for you.
Absolutely. For me, no issues. I'm waiting for you to say me go. So
thank you, sir. We'll take one more question before
someone will say it's too much, sir. Now you go. Please leave. Yeah, so they'll.
No, sir. Thank you so much for joining from all the way from Nagpur and taking out the time for us, sir. We are really, really humbled with your presence. Can we have one more question if we have any gynecologist or chairperson maybe wanting to ask? Yes. Yes, ma'am.
Hello. Yeah. My question is that what are the chances of a female with the GDM developed diabetes post-delivery, and what are the advices we should give her after delivery that prevent her from getting diabetes post-delivery?
I should congratulate you for this question, because yesterday we had a 3 hours, 7 to 9:30, almost 10 o'clock. I feel it was a vast meeting, and we had international people from US and Canada, and we were talking about pre-conception and postnatal follow-up. We did not talk about the gestational diabetes, and that is one of the pertaining issue in our country, that we don't have a postnatal follow-up. But if it is a pure gestational diabetes, 85 to 90% of these women will become normoglycemic within 48 to 72 hours after delivery. But around 10 to 15% of these women might remain glucose intolerant, and they might need to be on the diet therapy, if required pharmacotherapy, preferably again insulin. But these women, in almost 50% of them, will become type 2 diabetes. Almost 51.6% of these women might become type 2 diabetes in next 5 to 15 years of duration. And there is a very wonderful data which has come recently, that around 5.4% women within 7 years of GDM may develop type 1 diabetes. So that is why we have to follow rule of 6. Rule of 6 means after delivery, 6th day, 6 weeks, and 6 months. And then after 6 months, once in a year, you are supposed to screen these women for diabetes because they are potential candidate for development of diabetes in future. So every year you should be following them. Unfortunately, they disappear after the delivery. They neither go to a physician nor go to a gynecologist. They'll end up with pediatrician for first few years. So now we have to sensitize pediatricians that a woman who's coming with a child for vaccination should then be further emphasized on screening, and we can have a screening program at the pediatrician's clinic with those women who have GDM. So they can do it every that 6 weeks and 6 months program can be done. And again, last but not the least, Dhruvi, if you are screening a woman after delivery, up to first 6 weeks, rather up to first 6 weeks, you should not be trying to diagnose through HbA1c. HbA1c can be false low up to 3 months after postnatal, and it can be used only at the 6th month screening. You can use HbA1c or OGTT. Otherwise, you should do OGTT in the first 3 months after delivery for screening.
Thank you, sir. Thank you so much for all your cooperation and all the teaching that you have done for us today. I think since we are a little late in our time, we'll move on to our...
Waiting for this statement of yours, Dhruvi. So nice of you. Thank you very much. Opportunity. Nice meeting everyone especially Dr. Abhichandani, Dr. Dhruv, and Dr. Vipul, and you, all of you, and the whole team. And nice and happy Ganesh Chaturthi, happy Ganpati season to the IMA members of Ahmedabad. Congratulations for this wonderful event. Thank you very much.
Thank you so much, sir. Thank you. So it is because of all of you faculty that we've crossed a number of 250 online, and even in the hall with the COVID precautions, we have more than 70 people sitting. So thank you so much, sir, for joining us. And I'll move on to the chairperson to move on to our next faculty. Thank you so much.
Thank you, sir, for such a nice talk. The topic for the current session, the next topic is post-menopausal care. And for that, I would like to invite very senior diabetes and endocrine physician, Dr. V.K. Abhichandani, sir. He is a life member of RSSDI and member of other various associations. He is a principal investigators in various phase 3 trials. He is contributed a chapter in various books, and is a faculty and guest speaker at various regional and national conferences. Over to you, sir.
Yeah, so very good morning, everyone. I think most of you are real close friends. And well, side changer cancer. No, just full screen. So I will try to finish on time. I have been allotted a challenging topic by Vipul Dhruvi combo, and I'll try to do as much justice as I can. Handling a different laptop is always an issue, especially if you are hooked to Apple notebooks. Yeah, teacher. Okay. So I am going to cover these 4 headings: osteoporosis, CVD, hypertension, and DM in the quickest possible manner. So we are going to look at only post-menopausal ladies. So what is menopause? Menopause is a normal natural event defined as the final menstrual period, in shortly known as FMP, confirmed after 1 year of no menstrual bleeding. It represents the permanent cessation of menses resulting from loss of ovarian follicular function, usually due to aging. And what is post-menopause? It describes the years after the FMP resulting either from natural or premature menopause. And the importance of this post-menopause is, with current life expectancy, people live longer because of excellent doctors, excellent medications available, therapies available. So it has its own darker side. So with the current life expectancy, the postmenopausal years make up almost 1/3 of the lifespan of many women. So regarding osteoporosis in postmenopausal women, we must know that osteoporosis is preventable and treatable. That is at the bottom. Osteoporosis is defined as compromised bone strength, and it poses a serious health threat for aging postmenopausal women, especially by increasing the risk of fractures. In fact, 13 to 18% of women of age 50 or above have osteoporosis of the hip, and lower estrogen levels account for about 2/3 of the bone loss during the 5 to 7 years surrounding actual menopause. So the definitions based on BMD, that is bone mineral density, using a DEXA scan. We have 3 terms to be familiar with. First is normal, T-score greater than or equal to -1. Then we have low bone mass, also known as osteopenia, T-score between -1 and -2.5. And third is osteoporosis, which is T-score less than or equal to -2.5. Now, some of us might have come across the term Z-score also. That is why on the right side of the cartoon, you will see a small definition I have inserted. The T-score is a comparison of a person's bone density with that of a healthy 30-year-old of the same sex. And the Z-score is a comparison of a person's bone density with that of an average person of the same age and sex. That age, 30-year age, is removed in the Z-score. And we have the fracture risk assessment tool, which is basically there are risk factors which are looked at while calculating or using this tool. This is available online. Mike, one more. Okay, okay. So it's fine. Yeah, it's fine. So this is available online from Sheffield University website, and I have also inserted that link. And basically advanced age is from 50 to 90. Many grandmas live up to 90 and 90 plus even nowadays. So, and parental history of fragility fracture is a major risk factor. Female sex itself is a major risk factor. Current tobacco smoking, please note the word current. Ex-smokers are at much lesser risk. Weight on either extremes, high weight, excess weight, obesity, or very thin build. And then long-term use of glucocorticoids is a major culprit. Height, whether a person is stunted or very tall, rheumatoid arthritis, low femoral neck, BMD, prior fragility fracture in the same individual lady, and alcohol intake more than or equal to 3 units per day. And at the bottom you have, this works, but at the bottom you have for connoisseurs of alcohol, what is 1 unit is mentioned at the bottom, okay? And there are some secondary causes of osteoporosis. So what about management? So we need to counsel these ladies to alter modifiable risk factors, and treatment is indicated for all women with osteoporosis as well as for those with osteopenia with additional risk factors. Non-pharmacological intervention for osteoporosis, especially in the postmenopausal women, will include modification of general lifestyle factors such as smoking cessation, avoidance of heavy alcohol use. These are more of Western origin recommendations, but they do apply in our current modern day society. And ensuring regular weight-bearing exercise, that's very important. And all our ladies who are in perimenopausal phase should receive 1000 to 1500 milligram of calcium and 400 to 800 international units of vitamin D daily. Bisphosphonates and denosumab are anti-resorptive agents. They decrease vertebral fractures as well as non-vertebral fractures. And parathyroid analogs, parathyroid hormone analogs like teriparatide are anabolic agents and are used in patients who are at very high risk of fracture and who have failed therapy with anti-resorptives. So I can only outline these things. If I go into details, it is going to take almost 2 hours. So, and monitoring response to therapy is also very important. Bone turnover markers, particularly serum-based markers like serum CTX, C-terminal cross-linked telepeptide, and P1NP, that is pro-collagen type 1 and terminal propeptide. Both of these serum markers have a role to play in assessing the treatment efficacy and the compliance of the lady. So according to National Institute of heart disease, not breast cancer, is the #1 killer of women globally. And if you look at the CVD, including coronary heart disease and stroke, it remains the leading cause of death for women of years 60 or more. And CHD death rates, unfortunately, in younger women aged 35 to 59 are increasing for the first time in last 4 decades. And this is secondary to almost epidemic of obesity, diabetes, and hypertension. So the menopausal transition is associated with a decline in ovarian steroid secretion and very frequently with a progressive increase in body weight that is likely a reflection of total fat mass, working as an endocrine organ. And what are the sequelae? You have many comorbidities like sleep disorders, depression, stress, psychosocial factors, vitamin D insufficiency, rheumatoid arthritis, and diabetes per se, which is not mentioned here. And all these are when the lady accumulates fat around her abdomen. The excess visceral fat coupled with low vitamin D and dwindling levels of estradiol will give rise to increase in free fatty acids, in bad chemokines like leptin resistance, and it will lead to a decrease in the good chemokine, which is adiponectin. There will be endothelial dysfunction, lot of inflammation, oxidative stress, dyslipidemia. All this culminate into insulin resistance, metabolic syndrome, hypertension, and atherosclerosis. And this is an interesting slide. So not all overweight ladies are at risk. Among postmenopausal ladies with normal BMI, higher trunk fat is associated with increased risk of, so apple shape is not good. If your truncal fat going high is going to be a problem for that lady. And so it increases the CV disease risk, whereas higher leg fat, so a pear-shaped fat distribution probably is associated with decreased risk of CV disease, and this credit goes to an article in the European, published in 2018 in the European Heart Journal. So how we should assess our menopausal ladies, postmenopausal ladies for their risk of developing atherosclerotic CVD? So we must look at the past medical history, including history of hypertension, DM, lipids, you should review the lipids if they are available. If they are not, get them done, and check out of other autoimmune conditions in the lady, rheumatoid arthritis, rarely history of HIV. And regarding pregnancy, we must take a history specifically ruling out preterm labor, hypertension disorder of pregnancy, gestational diabetes, eclampsia, pre-eclampsia, and postprandial cardiomyopathy. And family history, social history, history of premature heart disease in the family, their lifestyle, everything should be documented. And some simple biomarkers and labs like BP, BMI, weight, waist, lipids, glucose should be resorted to. And we can use online calculators for risk stratifying. And in my humble opinion, QRIS3 is very applicable. It's available online. You can download that, very applicable to our population. And I would request my esteemed dear friend, Dr. Urman Dhruv sir, to have a comment for this. Which calculator does he like? Then what about hypertension in postmenopausal women? So interactions between gender, the genetic background, environmental factors, and changes in sex hormones, which is the most important. So you have estradiol coming down, testosterone increasing, and all this culminate into hypertension. So I'll highlight the importance of changes in estrogen-androgen ratios. They are accompanied by increased BMI, aggravated endothelial dysfunction. They will be due to increased BMI, sympathetic overdrive, renin release, angiotensin II increment, giving rise to renal vasoconstriction and hypertension. And due to endothelial dysfunction, there will be elevation of endothelin, which will aggravate the oxidative stress, induce further vasoconstriction, and contribute to the hypertension. So hypertension in postmenopausal women is a major medical problem. Why? because inadequate recognition and control of hypertension remain major obstacles in reducing adverse CV outcomes for these ladies. And what you always require is a multi-drug therapy, and this is mostly seen in our day-to-day practice. As women age, more than one tablet is required, maybe single pill combinations are preferred. And these need to be always combined with lifestyle modifications such as low sodium diet and exercise regimen. And diabetes and menopause, what to expect? I'm approaching the end of my presentation. With menopausal changes in the female sex hormone levels, diabetes control becomes really haywire, unstable, and women who gain weight during or after menopause can see an increased requirement of insulin or oral medications, and they become more vulnerable to the occurrence of genitourinary tract infections and candidiasis. They also experience lack of orgasm and dyspareunia due to vaginal dryness. Hot flashes and night sweats can disturb sleep and in turn contribute to the stress and impair the glucose control. These can sometimes be mistaken as signs and symptoms of hypos or high sugars, and they are actually termed as confounders. And we must remember that all our ladies with type 1 diabetes, they may experience menopause bit earlier compared to normal ladies. And that is why if they want to plan a baby or a family, they should do it in time. And referring briefly to the importance of HRT in select group of postmenopausal ladies where there are no contraindications, if you offer them judicious HRT, what are the benefits? There are 7% fewer heart attacks at the top. This cursor is not here. And then 10% fewer diabetes complications. There is a decrease in LDL cholesterol, 18% less small vessel injury, and decreased HbA1c. But having said this, there are monitoring protocols recommended, which include HbA1c every 6 months, and lipid profile, liver function, fundoscopy annually. DEXA scans, I usually recommend at least biannually, means at least every 2 years to be done once, even if everything seems to be cozy. And blood pressure check every 6 months, and if required more frequently with the help of family physicians. And screening for microvascular disease annually, that means fundus, USCR, and peripheral neuropathy screening. No, this is my last slide. Postmenopausal women have a number of unique health promotion and disease prevention needs. So we'll start here at the cholesterol level. We must assess atherosclerotic cardiovascular disease risk. So risk stratify these ladies with one of the online calculators available. Personalize with risk enhancers. Do they have additional conditions which will enhance their overall CVD risk? And reclassify with the help of coronary artery calcium if required and whenever needed. Blood pressure should be kept below 130/80. Physical activity is just like the general recommendation, more than 150 minutes of moderate intensity exercise per week, or it can be a combination of moderate plus high intensity or vigorous physical activity. If she is resorting only to vigorous activity, only 75 minutes per week. Aspirin, low dose aspirin is now out of fashion, but a select group of ladies with too many risk factors will definitely qualify for low dose aspirin as a prophylaxis. And type 2 diabetes, we have to control. Now, this particular part was touched upon very well by Dr. Gupta ji. So I will try to clarify this recommendation. Type 2 diabetes, especially in a pre-gestational lady, a lady who is already type 2 diabetic, you should control through diet and exercise. Has been a past story. Metformin is a primary therapy, and prior to conception, the planned conception, we have the luxury of using GLP-1 receptor agonists, injectable, or SGLT2 inhibitors. I am underlying the word prior to conception, so that the overall cardiovascular risk really comes down. Then you have diet, which can be modified in a number of ways. We must emphasize on intake of vegetables, fruits, nuts, legumes, fish for those who enjoy, and whole grains. And tobacco is a big no-no, whether the lady smokes, uses a snuff or chews some masala. So pharmacotherapy, you have nicotine, I think nicotine gum and nicotine tablets, chewable tablets, and then you have Champix. Occasionally you can try in a chain smoker lady. And behavioral intervention is again important. You have to reason out with the lady that if you continue to smoke, it's going to really damage the future of both yourself and your planned baby. So I believe this was my last slide. Thank you very much for your patient hearing. If there are any questions, criticisms, comments, everything is welcome. And Dr. Urman, sir, I requested you to have your comment for the calculator. So for especially for pregnant ladies, which yes.
Because it is more reliable, but there we don't go into the controversy of HDA.
And I think it was validated in Asian population in the UK. So thank you very much.
Thank you, sir. Thank you for such a informative talk on the topic. Thank you very much.
Yeah. So, women are from Mars. Why? The title of our next topic discussion. And for that, I would like to invite Dr. Shalini. She will be joining us online. She is a consultant diabetologist, director of Life Care Diabetes Center, New Delhi. She is consultant or diabetologist of Apollo Cardinal Hospital and Clinics, New Delhi. She is a recipient of many awards, and she has contributed numerous publications in the reputed national and international scientific journals and more than 35 chapters in textbooks. Over to you, madam.
Women in endocrinology is a very important subject that we often miss to emphasize more upon. And our president, Dr. Banshi Sabu sir, our chairman of RSSDI Gujarat chapter, there is another faculty, Dr. Usha Sriram ma'am, Dr. V.K. Abhichandani sir, all of us together, we are doing a lot on trying to create more awareness for women health. And that is why we thought that we would keep a session on women and endocrinology to, educate the doctors more on how to manage them differently. And that is why Shalini ma'am is going to talk upon why should women have a separate kind of a treatment.
Hello friends, and thank you Dhruvi and Vipul for having me here. It's always a pleasure to be associated with you. And thank you Dhruvi for allowing me to talk on a topic which is very, very close to my heart. So we've all grown up listening to the common adage, men are from Mars and women are from Venus. We've all grown up believing this. Have we actually ever wondered, what if men were from Venus and women were from Mars? Or actually, what if both were from Mars? Would women then get the care and attention that they deserve? Women's health matters. And it's time that all of us acknowledge this fact and start doing something about this. A recent survey from the Times of India group has shown that the NCDs, especially diabetes, obesity, and metabolism, are all showing a sharp rise when it comes to women. Deaths due to NCDs are completely overlooked. 7 out of top 10 causes of female deaths in India are due to NCDs, particularly diabetes, cardiovascular disease, and breast cancer. CVD is largely considered a man's problem, and breast cancer is perceived as a greater issue for women. However, do we know that cardiovascular disease is the top killer of women in Europe, resulting in almost 51% of deaths compared to only 3% of deaths with breast cancer? So women with type 1 diabetes have a 31% greater risk of death compared to their male counterparts. When it comes to women with diabetes, of course, 50% of people living with diabetes are women. Women with diabetes have a nearly 50% greater risk for cardiovascular disease And we lose the normal female protection we have from CVD if you get diabetes. Women with diabetes are 3 to 7 times more likely to develop or die of cardiac disease as compared to those without diabetes. Ischemic heart disease, strokes, these represent a major cause of mortality and morbidity in women, and women are more likely to be severely disabled after a stroke. So friends, there's a huge interest now in gender-specific cardiovascular medicine, gender-specific management of different aspects of different diseases. And special attention needs to be paid to women's health. And this is where I actually appreciate the efforts of RIMS, Dr. Vipul and Dr. Dhruvi. Dedicating a complete symposium to women's health issues is the need of the hour. Investing in the health of a girl, ensuring her physical, mental, social, environmental, and emotional well-being has a ripple effect not only on the good health of her family, but also the society as a whole. A woman is the axis on which the whole family revolves. Women are the pillars of society. They live in, and it's they who shape this society. Educating and taking care of one woman can benefit not one, not two, but multiple families that she is in touch with. A healthy society is the one that nourishes a woman. And these societies have better productivity, better quality of life. They create sustainable nations and strengthen their economies. PCOS, pregnancy, menopause, these are all issues that are very specific to women. A woman goes through various phases of her life: childhood, puberty, adolescence, pregnancy, motherhood, menopause, and postmenopausal period. Each of these phases impacts not only her hormonal health, her physical health, but also her psychological and emotional well-being. The social discrimination, gender bias, psychosexual abuse, all these often lead a woman to be considered as a second-rate citizen. Her health is always ignored. It's never a priority. How often do we see a woman accompanying her husband for his diabetes management? The husband has a full battery of investigations that is done, and the woman does not even want to take a proper consultation from you. Forget about doing a basic HbA1c. And this is what I'm talking about, what I see in a city like New Delhi, the capital city of our country. So I actually shudder to think what happens in the other places. So friends, it's time that we talk about health issues that are specific to women, their challenges and solutions. Lack of education, undernutrition, gender disparity, abortions, poor pregnancy planning, menstrual hygiene, menopause, osteoporosis, obesity, malignancies, prediabetes, diabetes, cardiovascular disease, metabolic syndrome, depression, everything impacts a woman's health. We never talk about gender violence, rape, child abuse, environmental and occupational bias. All of them impact her health, not only mentally, but physically also. So friends, women's health actually involves a conglomerate and balance of all components: physical, mental, socio-cultural, environmental, spiritual, emotional. Do women get all these? Do we understand the contribution of each of these dimensions to the overall health of a woman? So when we are talking about women's health issues, we actually need to address each of these dimensions and their impact on her health. We've had great lectures on PCOD, obesity, hyperglycemia in pregnancy, postmenopausal care. We've discussed cardiovascular disease, osteoporosis, hypertension, and diabetes in women. We've completely covered the entire life cycle of a woman in our discussions. We've had a diabetologist, a gynecologist, and an endocrinologist discuss these topics. Indeed, a welcome step by RIMS to get everyone talking on women's health. The risk factors associated with NCDs in women: physical inactivity, poor diet and lifestyle, stress, depression, mental emotional health, addictions, socioeconomics, each of these challenges needs to be addressed for the better overall health of a woman. Talking about obesity or diabetes or even hyperglycemia in pregnancy, the risk is limited not to the woman alone, but her unborn baby. We know intergenerational transmission of NCDs is no more a concept, it's a fact. Now we talk about GDM being a window of opportunity for NCD prevention. A pregnant woman with GDM is not only at an increased risk of developing diabetes later on in life, but the intrauterine programming of this unborn fetus to the stimulus of hyperglycemia puts this baby at a much higher risk of developing obesity, diabetes, hypertension, metabolic syndrome as it grows into an adult. So if this baby is a male child, he can definitely develop all of these problems. But if this baby is actually a female, she again has a very high risk of becoming obese, developing GDM in her pregnancy and later progressing to diabetes. So the vicious cycle of NCDs feeds on itself. So friends, female gender now we know is a key to NCD prevention. And as Dr. Seshia sir always says, focus on the fetus of the future if you want to prevent NCDs. Primordial prevention of NCDs starts from preconception. So it's time that preconception care, preconception planning becomes the norm. It all starts with a healthy pregnancy. And seeds for this are sown with a healthy intrauterine environment, giving birth to a healthy, optimal weight neonate who grows into a healthy newborn, a healthy child, a healthy adolescent, and eventually a healthy adult. Talking about this, literacy and education is also a very important and often disregarding aspect of women's health ecosystem, especially in a country like ours. They say you educate a man only. But if you educate a woman, you educate an entire generation. There is no greater pillar of stability in a society than a strong, free, and educated woman. A lot of nutritional challenges also need to be discussed when we're talking of women's health. Undernutrition, gender bias when it comes to feeding habits in our society, the preferential feeding for a male child, all of them impact the mother's and the baby's health. They impact a woman when she's growing up as a girl. Poor nutrition, undernutrition, again predisposes to a high risk of NCDs. Again, obesity, overnutrition, the other end of the spectrum, again adversely impacts not only the woman's metabolic and reproductive health, but also her mental health. As a governing council member of DIPSI and the only female member of the national EC of the RSSDI, I'm very happy to share that things are changing, and it's changing so much when it comes to the domain of women's health. DIPSI has always advocated optimal care for all pregnant women in India, especially in the context of GDM and pre-gestational diabetes. And very soon, we are coming out with a task force that is going to focus on all these different concepts of women's health. RSSDI has also launched the Sakhi initiative that focuses on the women's health, and we're compiling a book. We're coming out with a consensus. There are a lot of projects in the pipeline that will bring awareness, that will bring actual literacy when it comes to the health matters of the women. And as a core member of the DIVAS group, I'm very happy and proud to inform that we've just launched the Didi project, a nationwide movement with a mission to address all these different aspects of women's health. The vision of the Didi initiative is to empower every girl and every woman of our country with the knowledge and the tools that are necessary for prevention of diabetes and its complications and the related NCDs. Our roadmap to reach this goal is by involving one and all the women diabetologists, endocrinologists, physicians, gynecs, different specialities, the he for she men, the community at large, the policymakers, and most importantly, each and every girl and woman of our country has to be reached out through a number of initiatives. Actually, our first rollout was just yesterday. We had this great discussion and advocacy on GDM. We had both national and international faculties, including Professor Jean Connery, the president of FIGO, Professor Diana Ramos, the vice chair of California ACOG, Professor Ronald Ma was there, Professor Ravi Nakaran, who's done so much of seminal work in these fields. Everybody was there. We had Dr. Sunil Gupta, Dr. Rajiv Chawla representing the DIPSI group. So the whole idea is to spearhead a movement, to start a movement and have this snowballing, cascading effect to reach every nook and corner of this country. The cause of women's health is beginning to get visibility. The last few sessions in this meeting are proof of that. Every other conference, we've started talking about diabetes in women, women's health, cardiovascular disease in women. we started talking about women's health issues. A beginning has been made. We need to give it all the due attention and care that it deserves. We need to pledge our commitment, greater belief, dedication to champion the cause of overall well-being of a woman. And a big shout out to the Talibani mindset just a day before, when they said women cannot be ministers, they should just stick to giving birth. Friends, it's our task, our responsibility to provide our girls and women not only good physical and hormonal health, but also emotional well being, social security, respect, a safe and healthy environment to grow, to study, nurture them, and even at a safe workplace. Because women, I believe, are neither from Mars nor from Venus. We belong to this very earth. Remember, we say Mother Nature, Mother Earth. So, friends, women's health matters. Give her her due attention, respect, and care that she rightfully deserves as an equal human being. With that, I would like to end here and request all of you to make it a point to look at the woman who accompanies the man sitting in front of you for a consultation, because her health is equally important. She is the neck of the family on which the entire family is going to turn. So it's important we give her a good environment, care about her. A healthy woman leads to a healthy society, leading to a healthy nation. Thank you so much. And thank you, Dhruvi and Vipul, for giving me this opportunity to talk and share my views. Many thanks.
Thanks a
Hello,
lot.
friends, and thank you, Dhruvi and Vipul, for having me here. It's always a pleasure to be associated.
So we thank you, madam, for her very impactful talk. And this brings us to the end of the session. But before that, I suppose we have to ask a question to audience for the
one
prize.
question, sir.
So here it goes. The question is, at what gestational age or time do we screen for hyperglycemia in pregnancy? Option 1, at prenatal counseling. Option 2, at 16 to 20 weeks. Option 3, at 20 to 24 weeks. And option 4, at both prenatal counseling visit and at 22 to 24 weeks. 1, 2, 3, 4. Yes, sir. The fourth option, at both the prenatal counseling visit and 22 to. So you are right, sir.
Let us have a round of applause for sir. Thank you. It was the correct answer. We are moving on to a felicitation session for our faculty, Dr. V.K. Abhichandani, sir. Can I request Dr. Deepak Rao, sir, to please felicitate Abhi, sir. Abhi, sir, has been a mentor to us. He's been teaching us a lot of, diabetes, hypertension, GDM, and we've had the fortune of learning from him. Please, sir. Can I request our chairperson, RSSBI Gujarat chapter, Dr. Urman Dhruv, sir, to felicitate? Yes, sir. Yes, sir, please.
I am really humbled by what Dhruvi has said. In fact, I am standing in front of my mentors, Dr. Sanjeev and Dr. Urman Bhai. So really, I feel humbled.
Thank you, sir. Thank you for joining us today. Can I request Urman, sir, to felicitate Dr. Deepak Rao, sir, with a memento? Thank you, sir, for chairing our session today on women in endocrinology. Can I request Mona madam? She's been talking too highly of Sheetal ma'am all the time. And can I request Mona ma'am to felicitate our Sheetal Deshmukh ma'am, please? So we thought of having equal opportunity, equal number of women as our faculties today. And the inspiration of today's program also comes from a woman. With that, can I request everybody to, to start arranging? Till then, can I request Sanjeev Pathak, sir, to felicitate our one faculty who started the session today with PCOD, Dr. Nisarg Dharaiya, sir. He's the leading gynecologist, Pathak, sir, and he has the largest growing chain of gynecology clinics across Gujarat and very soon, I guess, across India. Dr. Nisarg Dharaiya, sir. We always keep the best for the last, is it so? Thank you, sir. So I again thank all the dignitaries present here, all the faculties who have joined us online, including Pratap Jethwani sir, Banshi Sabu sir, JP Sai sir, and all right. Thank you to everybody who've joined us online, all the delegates, all the faculties, all the dignitaries here. And with that, we will start our inauguration session for today. I'm not so good with Sanskrit or something, but hail to Lord Ganesha, and I would request somebody from the session. All right, we'll take 2 minutes till everything is set. Okay. All right, we're set, done. I'll start. Thank you. That is a perfect setting, nice, good chairs, and we'll start our inauguration session. And I heartily welcome all of you for being a part of our inauguration session, all the faculty for specially coming down for our inauguration session, and our sir for joining all the way from Abu and all across the India for the inauguration. Can I request, Sanjeev Phatak sir to felicitate Dr. Kirit Kumar Gharvi sir with a bouquet of flowers, and I request Kirit sir. Kirit sir. All right, Kirit sir. All right, okay, all right. We'll take 2 minutes till we have Kirit sir and Phatak sir. Can you request Dr. Dhiren Mehta sir to please come on the stage and felicitate sir with a bouquet of flowers, please. That is very fast of him to be running inside for the bouquet of flowers, and I hope that helps him, keep him away from. Sanjeev sir, can you felicitate Dhiren sir, please? Phatak sir is a leading diabetologist and Dhiren sir is our honorary secretary, Ahmedabad Medical Association. So please have a seat on the dais, Dhiren sir. Can I request Urman sir, our chairperson, RSSDI Gujarat chapter, to felicitate Dr. Mona madam with a bouquet of flowers. Mona ma'am is the immediate past president for Ahmedabad Medical Association, and she's the inspiration behind today's program for us. We'll have one more bouquet. And Mona ma'am, can you felicitate Urman sir, please? Yes, sir. Mona ma'am. From Mona ma'am to Urman sir. Thank you. From one immediate past president to our incoming for our chairperson, RSSDI Gujarat chapter. We have Dr. Banshi Sabu sir, who's connected online, and since we cannot felicitate him physically, our virtual bouquet of flowers to Dr. Banshi Sabu sir, who's our mentor and the president, RSSDI National RSSDI. RSSDI is the Research Society of Study of Diabetes in India and one of the largest organizations for diabetes, diabetologists, and all healthcare professionals interested in the field of diabetes. Can I also welcome Dr. Vipul Chavda sir, who's the chairman, Rudraksha Institute of Medical Sciences, and the organizing secretary for our practical diabetology. Can I request Dr. Gargi Patel ma'am to felicitate Vipul sir with a bouquet of flowers, please?
Durvi, thank you. Thank you for felicitating.
Thank you, Banshi sir. Thank you for joining with us all the way from Abu sir. Thank you so much.
Thank you. It's really pleasure.
We have Kirit sir, and can I request Urman sir again to felicitate our Kirit Kumar Ghadvi sir. He's our president, Ahmedabad Medical Association. Thank you so much, sir. Thank you. Welcome Pratap sir, Dr. JP Sai sir. Our virtual felicitation to all the faculties who've connected online. Thank you, sir. Project nahi tha tu par. All right. Thank you, sir. Thank you all of you for joining. And with that, can I request Kirit Kumar Ghadvi sir to say few lines as a welcome address for all our audience who are watching us virtually as well as physically, sir.
મિત્રો બેને એક જ લાઈન બોલવાની કીધી છે એટલે હું એક જ લાઈન બોલીશ. defeat diabetes. Defeat diabetes is our target, right? તો આપણે જે અત્યારે ડાયાબિટીસ અવેરનેસ માટે જે પ્રોગ્રામ કર્યો છે એ એના માટે જ છે કે આગળના સમયમાં આપણે ડાયાબિટીસને ગમે તેમ કરીને ડિફીટ કરવો છે. તો હું ખાસ વિશેષ આ ડાયાબિટીસ લોકોને બહુ જ આપીશ કે આ પ્રોગ્રામને વધારેમાં વધારે લોકોમાં લઈ જાય અને આની અવેરનેસ લાવે અને આપણે શ્યોરલી ડાયાબિટીસને ડિફીટ કરીશું. થેન્ક યુ વેરી મચ.
Thank you so much, Garvi sir. Our chief guest for today, Dr. Mona Desai madam, and she's our immediate past president for Ahmedabad Medical Association. Can I request ma'am for a few words, please?
First of all, good morning to everyone and welcome on behalf of Ahmedabad Medical Association to this wonderful session, I would say, of practical diabetes. I really congratulate the whole team of REAMS, especially Dr. Vipul Chavda and Dr. Hasnani, Dhruvi Hasnani. You both are really vibrant and you have wonderfully arranged this whole CME. You have covered, I think, every aspect. All ICUs and women and child and endocrinology. I think in a small concept way, it was excellent. I think after today, like once the CM is over, those who are attending here physically and those who are online, I think you people will be gaining a lot. So it is once again the whole team of REAMS, congratulations for flawless CME. So this is really nice, and I always felt that juvenile diabetes, that is type 1 diabetes, is one part which has been literally very much, I would say, not taken into consideration by our government. Nothing has been done, and maybe in future, if we have this kind of programs, our government will also be sensitized to do something about the small kids who are suffering from diabetes. And I'm sure you all, Dr. Bansi Sabu and Reams and all, you all working so hard on this subject would at least sensitize and help our children and adults in our country to cure these diseases, or not cure maybe, but at least bring control. So once again, thank you so much for giving me this opportunity, and I'm so happy that today we are all here physically and learning this wonderful topic. So thank you so much.
Thank you so much, ma'am. You were really an encouragement when we wanted to plan something. I would like to request Banshi sir, he's online, and sir, if you want to, say some few words before we talk about defeat diabetes.
Thanks, Durvi. Durvi, I think I made the recordings, but first of all, congratulations to Vipul and Durvi for this practical diabetology. I fully agree with Dr. Mona Ben. Just now she talked that in this practical diabetology, we try to cover all aspects of diabetes, including pediatric diabetes. We are very happy. Today, we will be having live session from Karin also. She is President of International Society of Pediatric and Adolescent Diabetes. And as pediatric diabetology, I will say it's less recognized problem, but it is not less. The number of persons with type 1 diabetes in our country is second highest after the US. As Mona Madam is a immediate past president of Indian Medical Association Ahmedabad, and she's a pediatrician also. She understands the importance of type 1 diabetes. But the most of medical practitioners, and they neglect this problem and they still consider that it's one other variety of diabetes, or it's a diabetes which occurs just in pediatric, and the way we are treating adult diabetes, the similar way they are to be treated. So I think a special consideration on pediatric diabetes should be a part of regular IMA practical diabetology course. That is what I wish from, and I request even our IMA President Ahmedabad branch to have a regular course on pediatric diabetes. Regarding defeat diabetes, I have recordings for 7 minutes, so it will be good if I can show that. If we can show that, I will request RX events, because what defeat diabetes campaign which First of all, thanks. Yes, Dr. Mona Desai. She is a past president of Indian Medical Association Ahmedabad branch. Our guest of honor, Sri Babudas Bhai Jamnadas Patel, who is member of large assembly, Gujarat State. Dr. Kirti Kumar Gadvi, who is president of Indian Medical Association Ahmedabad branch. Along with that, Dr. Vipul Chavda, who is also here with us, and thanks Rudraksha Institute of Medical Science for coming out with a very fantastic program on a practical diabetology. First of all, it's a program of hybrid meeting where most of you are here present. Unluckily, today I am not physically present here. So for that, I am sorry. What 5 or 7 minutes, I'll be talking about Defeat Diabetes. A Defeat Diabetes, a campaign which we have initiated from RSSDI. I am currently the president of RSSDI. And Defeat Diabetes campaign have a tagline of testing, tracking, and treatment. Now, why we started this campaign? For two reasons. One is, during COVID time, what we have seen, those who have uncontrolled diabetes or those who are detected first-time diabetes found to have worse outcome in compared to the those who have controlled diabetes or those who are not diabetic. So that's one reason. The second was, there was a paper which was published from American Diabetic Association in Diabetes Care, and they have also compared with the similar type of condition with the uncontrolled diabetes, with the controlled diabetes, and they had come out with a paper that sugar monitoring should be considered as a fifth vital sign. And on the same paper, we have written also in India paper along with Dr. Anup Mishra and Dr. Jyoti Dev, and I was the author for that paper that sugar should be considered as a fifth vital sign. The way each and every one who is monitored for the temperature, for pulse, for respiratory rate, oxygen saturation, or for the blood pressure, the similar way, each and everyone should be tested for the sugar also. Now, this is not only for the persons who are getting hospitalized, rather than it should be also for those who are coming to the outdoor patient department. Now, today we are talking in IMA, where I'll be requesting all the clinicians who are may not be the physicians or may not be the general practitioner. They may be ophthalmologist or a pediatrician or a gynecologist or an orthopedic surgeon. So they are checking for each and every patient all those 4 vital signs, and they are forgetting that sugar monitoring should be considered as a part of vital sign assessment, and they should check it regularly also for each and every one who is coming to our clinic. And rather, we should not miss an opportunity in adult persons who is coming to your clinic for not testing their sugar. That's number one part of it. So the testing is very important. Otherwise, also 50% of our diabetic patients, they don't know whether they are diabetic or not. So the testing will tell us if we will achieve the early, we will get the early diagnosis, we will able to get a tighter glycemic control for these patients. Otherwise, they will come with a complication. The second important part is the tracking. The tracking for whom? Who are at the risk of developing diabetes or those who are already diabetes. So they should be tracked regularly. They should be monitored regularly. So those who are non-diabetic, but still we are tracking them regularly for sugar detection, as well as if they are having higher abdominal girth, they can be at the risk of developing diabetes for prevention of diabetes. Those who have diabetes, their sugar is to be monitored, tracked regularly to know about the status of their sugar. And if they are uncontrolled, they should have an aggressive treatment, and that is what the treatment. So then Defeat Diabetes and a campaign with a test, track, and treat. And we want to make it more popular in the lay persons. More popular, the diabetes can be defeated if we do testing, tracking, and treatment, and this should all IMA doctors should do. This initiative is being supported by Indian Medical Association. Also, along with that, Indian Association of Clinical Pathologists who are running the laboratory, and Art of Living Foundation, Rotary Club, supported with the Torrent and Beto One, a glucose meter company. More than 5,000 doctors from RSSDI are
following it very regularly on our social media campaign, and in last 70 days, more than 75 million people we reached already. Now, from this week onward, we are starting with radio campaign. We are on 29 September on one particular day, 1 million people will be tested for the sugar all across the country, and that itself will be a world record on one particular day to check for 1 million people sugar. So I mean, that is what our Defeat Diabetes campaign, which we are going to do. From 2nd of October, we are going to come out with a satyagraha against this diabetes, and we are going to launch a Vijay Rath from Sabarmati Ashram, and we will be reaching Delhi on 10th of this month when our 100 days of this Defeat Diabetes campaign will be over. So that's our plan, and we have already achieved more than 70 million people who are talked about this, and our mission to test, track, and treat our 3 pillars of diabetes, defeat diabetes, are almost like we are achieving this campaign. Our mission is to reach 100 million people, and which we are, I think we will able to achieve. But our vision is this defeating diabetes campaign should continue. It should continue for many more years, because this cannot be just 100 million people to whom we are reaching out, but it should continue to do, because we want to test everyone, each and every adult individual. We want to track all those who are at the risk of developing diabetes for prevention of diabetes, as well as those who are having diabetes, their sugar is to be controlled and they should be treated for aggressively, they should be controlled, and complications should be reduced in our country. So we want to make our country not just a diabetes capital of the world, rather than a diabetes care capital of the world, a complication-free diabetes world in our country. With these words, once again, thanks Dr. Durvi and Dr. Vipul for giving me this opportunity to discuss about defeat diabetes in this innovation. Thank you very much.
Thank you so much, sir. Those were actually the President's words, the words of Dr. Banshi Sabu, the President of Research Society of Study of Diabetes in India. We are running a campaign of defeat diabetes, and that is what he was talking about. We are trying to reach 1 million people in 100 days. We have almost reached the peak, the summit, and we request everybody present here to try and check RBS as one of the 5th vital signs in all our patients coming to our OPD setup. With that, I am going to request Vipul sir that we have to felicitate Dr. Sanjeev Pathak sir with a bouquet of flowers once, please. And now I would like to request all the dignitaries present here, as well as Urman sir, Gargi madam, Sanjeev sir, Pragnesh sir, all of you to be present on the stage for a lamp lighting ceremony.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
our rituals, our culture is one of the mainstay, what makes us, builds us, and takes us into the future very, very positively. And I thank all the faculties present here for, uh, being here, for making this day more and more auspicious. And with that, I'm going to request Dr. Vipul Chavda sir, who's the chairman, Rudraksha Institute of Medical Sciences, to say a vote of thanks.
Thank you so much, everyone. It was very wonderful and heart-touching moments for all of us. Our respected dignitaries off and on dais, doctors and my friends, I feel honored to pronounce the vote of thanks on behalf of Rudraksha Institute of Medical Sciences. First and foremost, I would like to thank Almighty God for blessing us all and bringing us all together after this massive pandemic that we have faced. I humbly thanks our guest of honor who is not able to present because of a political crisis in our state recently, Sri Babudas Jamnadas Patel, and our chief guest, Dr. Mona Madam Desai, for gracing the occasion. And without Mona Ma'am, this program would not have been possible. Thank you, Madam, for the support. I would like to humbly thanks our own dignitaries sitting on and off dais, Dr. Kirit Kumar Gadhvi sir, who is a president of Ahmedabad Medical Association, Dr. Dhiren Mehta sir, secretary of AMA, and our own Dr. Urman Dhruv sir, and my teacher, my mentor, Dr. Sanjeev Phatak sir, and Dr. Bansi sir, who has been always my teacher, my mentor, guiding my energy to the positive way, who is even though not present in Ahmedabad, present digitally on this podium, Dr. Bansi Sabu sir. I would also like to thanks all the chairmen, all the speakers of the conference, and all the national and international faculties who spared their time to present here digitally, including Dr. Jimit Vadgama, Dr. Bharat Sabu, Dr. Nisarg Daraya, Dr. V.K. Abhichandani, and Dr. Karin, Dr. J.P. Sai sir, Dr. Vijay Patni sir, Dr. Salini Jaggi madam, and last but not least, Dr. Sunil Gupta sir. I would also like to thank the whole team of RX, Dr. Hardik Chandrana specifically, for executing the event so well. And I would also like to thank our industry partner, Nord Nordisk, Torrent, McLeod's, and all other who supported us very well in the last year. I also like to thank the energetic team of RIMS, who worked tirelessly in the effort to make this conference successful, particularly Vishal, Komal, Deepak, Rakesh, and all our team, including Vaisali and Urvasi. At the end, I would like also to thank the Ahmedabad Medical Association, the team of Ahmedabad Medical Association, in particular, our President Kirit Kumar Gadhvi sir, our Secretary Dr. Dhiren sir, and immediate past President of IMA, Dr. Mona Madam, to make this event possible. In the end, I would like to thank my mother, my kids, and my family for the constant support. If by mistake I have forgotten anybody, it is purely unintentional. Thank you all. Thank you so much. Jai Hind. And I really forget one important name, the whole Dhruvi of this program, my colleague, my partner, who is a scientific chairman, secretary. Please, round of applause for her.
At last, how can we forget to felicitate the whole program manager? I would like to invite Dr. K.C. Gadhvi Sahib, President of the AMA, to felicitate Dr. Vipul Chavda. Please. Vipul. I would like to invite Dr. Manavan Desai to felicitate Dr. Dhruvi Asnani. Thank you so much. And without wasting much of time, we will now going to proceed for the next part.
there is something that we wanted to share with all of you. What started in 2011 as a multi-speciality hospital in Bareja. Most of you must not be knowing Bareja is a small developing town on the outskirts of Ahmedabad. It started by a single-handed person, Dr. Vipul Chawda, and today it is growing into an institute with 2 centers, one super speciality center, one multi-speciality center, and we are trying to incorporate education of healthcare professionals, education for nursing, and we have a wisdom institute for education of all the healthcare professionals interested not just in diabetes but in the healthcare sector as well. We are growing in the digital media space. We are growing into the diagnostic center space. And with that, I would like to request the RX team to play our video. The Almighty, our parents, our family members, our colleagues, our elders, our mentors, our gurus. We are entering our second year as Rudraksha Institute of Medical Sciences, celebrating 10 years of Rudraksha Multi-Speciality Center and 1 year of Rudraksha Super Speciality Center. We thank all of you for being a part of it. Thank you so much. Can we have the national anthem to close the inauguration ceremony, please? Okay, all right, we'll play it in the last. All right, thank you. Sure, thank you so much. So with that, I am not going to bore you further.
So thank you so much. It was a wonderful inauguration ceremony, Dr. Dhruvi. And now we are entering the third session. I know we are a bit late. So without wasting much time, I would like to call upon the stage the chairperson of the third session, Dr. Gargi Patel, madam. Please, ma'am, on the stage. And Dr. Dhiren Mehta, sir. This session is about pediatric diabetes. And over to you, chairpersons.
Hello. Thank you very much for the chairing session, because Dr. Bansi Sabu is also mentioning about the pediatrics diabetes. Mona madam is also mentioning it is always underestimate. I am not telling like that it is a not diagnosis. As we know, the pediatrics diabetes, that is a type 1 diabetes, is insulin dependent diabetes. Pancreas produce very little amount or the no insulin. So child needs or the patient needs insulin to for the survival. So now like it, I'm not wasting so much of time. I'm just only say one word like that. Like a type 2 diabetes, one diabetes is also increasing trends. Recent data suggests it should be like 3 to 5% increase per year, type 1 diabetes. So we must be give attention to the type 1 diabetes. As a pediatrician, we know the patient directly come with like diabetes ketoacidosis. Then it is very difficult to treat also. Second thing, because of the recent advance in the development of the blood sugar monitoring and the carbohydrate counting and the delivery system of insulin, now the quality of the children is also life of the diabetes children is improved. So with keynote, we have a panel of experts who will shed the light on the pediatrics diabetes related topics. First of our speaker is the Dr. Dhruvi. I don't think the any introduction because since the morning she needs introduction, but just for that, I think she is a MD. She is a very young and dynamic. She is a head of department of the clinical regimes. Consultant diabetes, Rudraksha Institute of Medical Science, treasurer of the RSSDI Gujarati chapter, and winner of the Torrent Young Explorer Award for the diabetes. Faculty for the National Diabetes Educator Program, speaker at the numerous international and national conference, 10 international and 25 national publication, and the reviewer of the Pediatrics Diabetic Journal and Journal of Diabetes. Investigation. Over to you.
All right. Before we used to call it juvenile diabetes. Now it is no more called juvenile because type 1 diabetes occurs even in elder population. And we are seeing a lot of adolescents, a lot of young girls coming with pre-diabetes, coming with symptoms of type 2 diabetes, and a lot of post-pubertal kids with obesity who are diagnosed with type 2 and other forms of diabetes because of endocrinopathies, either because of obesity or any other kind of, endocrine disorder. Growth, retardation or underdevelopment, not achieving milestones. One of the reasons for that is hyperglycemia as well. So, all right, now there are pediatricians, there are diabetologists, but when we all work together and when we are managing type 1 diabetes, we all say that we have to become pediatric diabetologists. There are special training programs for pediatricians. There are associations who are training pediatricians as diabetologists and who are training diabetologists to be looking into the pediatric aspect as well. And we have to work as a team, and that is what I'm going to be talking about today. Type 1 diabetes, when we talk about it in India, there are various challenges that we are facing, be it unawareness, be it lack of knowledge amongst doctors, because family physicians or normal physicians, MDs also do not encounter type 1 diabetes as often as type 2 diabetes. And most of the time, if a child is complaining of any symptoms of hyperglycemia, it gets misdiagnosed and it is quite late by the time a person or the child is diagnosed with type 1 diabetes. They already have landed up in DKA. And in a lot of countries, DKA is not the symptom for type 1 diabetes onset, but regretfully, unfortunately, in India, it is still the factor that we have to keep in consideration. When we are talking about Southeast Asia also, India ranks #1 in the prevalence of type 1 diabetes. Is it our population? Is it our genetics? Is it something else that is causing the increase? Like Gargi ma'am was saying, that the prevalence is increasing. First, it was say 1 in 1 lakh kids below the age of 15. Now it has increased to more than 3% and 4%. Now, what are the essential components when we talk about managing type 1 diabetes? It is medical nutrition therapy, of course. Insulin is something that we should not forget. There are various kinds of insulin that we can give, but insulin is the only answer. A lot of controversies are going on as to people talking about cure of type 1 diabetes, which is not possible. Please, consult a good pediatrician, a good diabetologist when it comes to type 1 diabetes in your child. Monitoring, diabetes self-management education, these are two basic pillars which constitute the essential components for management of type 1. And psychosocial support, not just of the child, but also of the parents. The psychosocial element is often neglected and which has to be kept into mind. Now, this is a very, very beautiful slide which we are using across a lot of diabetes conference, and it says that the challenges is not just on the community level, it is also on the family level, it is also on the school culture and even the healthcare system when we talk about challenges that are present in management of type 1 diabetes. This is a paper. Pratap Jethwani sir was present in the inauguration time. Pratap sir and Banshi sir and myself, we came out with this paper talking about what could be the challenges when we are talking about COVID-19 pandemic and management of children and adolescents when it comes to type 1 diabetes. So we divided the challenges into very basic three components. We talk about diabetes self-management, we talk about challenges related to the healthcare system, and we talk about the psychosocial aspects. So insulin therapy, ma'am very well said that insulin cannot be missed, insulin cannot be neglected. It is the only answer when we are talking about management of type 1 diabetes, be it in children, be it in adolescent, young adults, or geriatric population. And the accessibility of insulin, the availability of insulin across the country is something that is a challenge. A lot of organizations, even Government of India is providing free of cost insulin, but that insulin, if given without proper education, makes no difference whatsoever to the child. The child could be taking premix insulin or basal bolus or human or even analog insulin, but without proper education of what insulin is to be taken, when it is to be taken, how is to be taken. If we are not taking care of this education part, the insulin therapy is not going to benefit the children at large. RSSDI, which we've been talking about since the morning, has conducted a network, a type 1 diabetes network, wherein RSSDI is trying to reach all the healthcare professionals across the periphery for supporting kids who do not have access to type 1 diabetes. So all of you sitting here, if you have any troubles with accessibility of insulin for your patients with T1 type 1 diabetes, please contact any of the RIMS team or RSSDI team. Glucose monitoring. Well, insulin apididu, that's not the answer. Like I'm saying, monitoring again, the children, the young adults, or even the adults do not have a monitor wherein it will say karikitlu sugar gayu. Monitoring vagar insulin therapy again is not beneficial. Insulin and monitoring go hand in hand when we want to achieve best results in our kids with type 1 diabetes. There is an individualized approach when to check, how much to check, and how to check. Technology has grown and there are various sensors, invasive as well as non-invasive, real time as well as retrospective when we talk about glucose monitoring. A simple sensor that can be stuck to the hands or upper arm, and there is continuous real time data monitoring. The parent or even the adult can look into their phone. They just have to look at the screen and see what the sugar is, take the shot of insulin, and well, that is fine. Medical nutrition therapy, proper and healthy diet. People feel diabetes third le fikku khavanu. Even for the kids, there is a lot of torture. Aa khavanu, pillow nahi khavanu. That's not the answer. A healthy, a balanced diet is the answer for everybody with diabetes, whether it is type 1 or whether it is type 2. Physical activity, again, kids with type 1 diabetes can be moving around. They can have any sport activity in their regular day-to-day lifestyle. Without sports, these kids are not going to have proper milestones, and Mona ma'am is going to talk about that in her next lecture. Sick day management, something very, very important. Kids come to us with viral infection, most of the times going to the pediatrician for acute condition of infection. This is the time where the parents need to be taught what has to be done: increased monitoring, hydration, and frequent and shorter doses of insulin is the answer for a sick day management. There is a small flyer, a very, bullet points, a very short and sweet message that needs to be given by the team, diabetes care team, that is taking care of the kid and their parents as to what has to be done on sick days. Emergency preparedness, like the times of COVID, these were unprecedented times, and emergency kit has to be always kept prepared, whether there are floods, whether there is loss of electricity, whether there are any other emergency situation. There is a small hypo as well as hyper kit, which constitutes of insulin, the very first thing, glucometer for monitoring, and surplus supply of battery as well as insulin cartridges or insulin bulb to manage at least 5 to 10 days for emergency purposes. Type 1 diabetes and COVID-19, not enough has been said. Even vaccines which are developed for kids are not talking much about what has to be done for type 1 diabetic kids. And there have been various studies that are showing that with type 1 diabetes, the COVID-19, when they got inflicted, the mortality was high with uncontrolled sugar. The only answer came that if the kid with type 1 diabetes is managing the sugars well, the complications of COVID-19 were less and less. This was a study by the NHS. This was a very, very simple slide, which I thought to include what documents are needed, what medications and what other materials are needed for an emergency supply kit for management of type 1 diabetes during these pandemic times. There are also challenges related to the healthcare system. A routine healthcare support team is required. A doctor or a physician, a pediatrician or a consultant diabetologist might not have the appropriate amount of time that is required for not just giving the advice, itna insulin le lo, itna sugar test kar lo, but there needs a nutritionist, an actual social worker, and a psychosocial counselor to talk to the parents, because they are guilty all the time that it was something that we did because of which our child got type 1 diabetes. The kid feels that maine kuch kar liya hoga, that is why I got type 1 diabetes. And it takes a lot, many counseling sessions for the kid as well as the parents to accept the fact, to come to terms that insulin is one of the therapy, and right now it is only available in an injectable format. We need to educate doctors more. We need to talk to more healthcare professionals as to what needs to be done, what changes are needed to be done in the healthcare system for better management of type 1 diabetes. The psychosocial aspects, which are not much talked about. When the American athlete moves out of the Olympics, everybody wants to talk about mental issues. When Deepika Padukone says, I'm depressed, everybody wants to talk about mental issues, but nobody wants to address it in our day-to-day regular OPDs. Nobody wants to ask this as a part of their regular questionnaire. Aap theek ho? Are you happy? Is the answer. Even if your sugars are bad, the numbers do not matter. Are you healthy and are you happy? Are something that we miss asking our kids, asking our young adults, and asking even our other older population, be it type 1 or type 2 diabetes. The solution lies into, taking care of the holistic approach, the holistic management. We have to incorporate technology, exercise, nutrition, medical care, psychosocial support, family dynamics also. You have to educate grandparents, friends, chacha chati, mama mami, foi fua, badha needs to know that, this is what needs to be done for a proper management of the child. The growth needs to be addressed. A pediatrician needs to be involved just as equally as a diabetologist. There is a whole type 1 diabetes community of kids, of young adults, of adults who are, who have gone through this situation. And it is always nice to talk heart to heart with somebody who understands your situation. So we need a holistic support. We all need to get together. There are various programs going on, changing diabetes in children by the Novo Nordisk. There is a Life for a Child program by the ISPAD. There are lots of associations, the RSSDI, the Diabetes India, a lot of Indian organizations working for the betterment of life of people with type 1 diabetes. We no longer call them patients. There is a whole system, whole group talking about language matters. You no more call them diabetic kids. You no more call them patients. These are all people living with type 1 diabetes. They are not suffering. They are living, and they are very well happily living with the situation they are in. Maybe I might also falter sometimes, and there are people who, help me correct the situation. We have a type 1 diabetes registry. I want to address all the pediatricians in the audience today. We have a type 1 diabetes registry, and it is run by a whole association of pediatricians, and it is a society, International Society of Pediatric and Adolescent Diabetes. And Banshi sir and myself, we are a part of it with other 12 centers from across the country. And it is definitely helping us to talk to one another, get all the good practices. This is something that we are incorporating. They are doing some camps. We can always get together, talk about the good ideas, how we can benefit the people with type 1 diabetes. Education, education, and education. Like, in the morning, Dr. Jimit was saying all the 10 points, avoid sliding scale. We say for type 1 diabetes, education is the only answer. And you cannot falter if you are educating your person, the patient or the child with type 1 diabetes well. So with that, I'm going to close the session and, take over to Stuti. We've compiled a small video of of all the kids. Can we have that right now? Yeah. So I wanted to show that there are kids, there are adults, and there are people with type 1 diabetes who are living very, very happily. They are moving on with their normal lives, and a lot can be done with type 1 diabetes. We've done the type 1 diabetes challenge. We've taken people to Kalsubai for trekking. That's a peak in near Aurangabad. We've taken them to Greece. The ISPAD, the Pediatric Association, took them to Greece. And with that, I think I should.
हेलो फ्रेंड्स, मेरा नाम अभिजीत है।
रामसुख भाई मेरा नाम है।
મારું નામ જય છે। મારું નામ આર્યન પરમાર છે। My name is Kashish. I am type 1 diabetic patient. Type 1 diabetes શું મારું સુગર કંટ્રોલમાં રહે છે। Diabetes type 1 का पेशेंट हूँ। मैं 2 टाइप के इंजेक्शन लेता हूँ।
અને ઇન્સ્યુલન્સ રોજ लगता है।
હું ઇન્સ્યુલિન લઉં છું, મારી સેહત સારી છે। I am taking insulins regularly and keep checking my sugars. I eat everything what I like. હું દરરોજ ઇન્સ્યુલિન લઉં છું, હું જીમ કરું છું, હું મનપસંદ જમી લઉં છું, હું ફરવા જઈ શકું છું, હેપી લાઈફ જીવન જીવું છું। થેન્ક यू।
इसी तरीके से जिंदगी में जी रहा हूँ। टाइप 1 डायबिटीज है, कोई तकलीफ नहीं है मेरे को, रोज दवा ले रहा हूँ, अच्छी तरीके से जिंदगी मेरी चल रही है, कोई तकलीफ नहीं है।
Living like a normal healthy life like my friends. I go to sports activities, dancing and all. I be in touch with my doctor at RIMS. Thank you. और मैं अब हेल्दी फील करता हूँ पहले से, और मेरा शुगर भी कम आता है, और मैं अब स्कूल भी जाता हूँ और मेरे फ्रेंड के साथ खेलने भी जा सकता हूँ। थैंक यू।
Hi everyone, I am Dr. Anushri Mehta. I am a diabetologist and I have been living with type 1 diabetes for the last, I think, 22 years. Very important mantras of living healthily with type 1 diabetes which came to my mind. First mantra of living healthily with type 1 diabetes is complete acceptance of your medical condition.
I think we should be applauding all the kids and people living with type 1 diabetes. With that, thank you so much, and I hand over the stage to the chairperson.
Thank you, Dr. Dhruvi, for the nice and inspirative words and with inspirative video also. One thing you should very rightly mention about that emergency kit with hypo and hyper, that is a very good, along with challenge and solution, very nicely narrated. Thank you. because of time constraint, there are lots of questions me also, but we should discuss in the later on as a pediatrician. Okay. Okay. Now we move on to the second lecture. It's my pleasure and honor both to introduce our next speaker, Dr. Mona Desai. I think there's no need to introduction because everyone knows her, but just few words about that. She told only one sentence is about me, but I am not agree. So I am two pages say one thing. I will do it. She is a practicing pediatrician and neonatologist, child and adolescent counselor since last 32 years in Ahmedabad. She is a member of Action Committee of the Indian Medical Association. At present, she is a state chairperson of the GSB Women Doctor Wing Gujarat chapter, as well as Ahmedabad also. Dr. Dhruvi and Dr. Bansi Sabu is already mentioned. She is a ex-president of the Ahmedabad Medical Association. One adjective I want to add is that she is the first lady PG president in the history of 180 years of the Ahmedabad Medical Association. That is the feather. And one most important thing is she is the first woman doctor who represent the India in the World Medical Association. This is the also one of she received so many awards like Dr. Kanak Goyal Awards from IMA headquarters for the year 2007 and 2008. Okay, only last award because there are the list of awards. So I will due to her. She looks like that. Her body language is not allowing me. The only award that is she received last year is a Corona Warrior Award 2020 from IMA headquarters. And apart from this academic excellence, she is adapted the 1,000 children of the 4 municipal college of the Maninagar and giving the free treatment health checkup to the all 1,000 children also. Thank you, Mona Ben, for giving us nice talk. Thank you in advance.
Thank you so much. Thank you, Gargi, for this exaggerated introduction. But thank you so much. Okay, with a constraint of time, I'll be going very fast because as Dr. Dhruvi said, we are running late. I'm going to talk about growth and development in type 1 diabetes mellitus. As I already said, and as Dhruvi said, that it is no more called juvenile diabetes, but I differ with her because this type 1 found in adults is because it has been missed in childhood or adolescent age. It never starts in adult. No, this is because you miss the diagnosis in the younger age group and you diagnose this insulin dependent diabetes in the adult group. So that is why it is called. So now we know this type 1 diabetes. It is, I'm not going into details, you all know, because some immune response of your body which destroys the cells of pancreas, and no insulin or very less insulin is being formed, and usually it is genetic, and that's why it is genetic, and this pancreas, as you all know, is not producing, so you have to take insulin for the treatment because no oral drugs are going to act on type 1 diabetes, and usually this diabetes is diagnosed during the childhood and adolescent age group. So what is the difference between type 1 and type 2 diabetes? Well, with type 2 diabetes has already been learned by us in the previous lectures. If there is, if in the starting phase with type 2, if you are changing your lifestyle, if you're changing your diet, you might come out of it. But with type 1, this does not work. You have to take medications, right? But the symptoms are same. The symptoms of type 1 and type 2 are absolutely same. They are mirror-like. We have polyuria, polydipsia, polyphagia, all of you know this. And in children, there is feeling of irritability, fatigue. I think in adults also we find all these things, weakness, unexpected weight loss, feeling of hunger, and nausea. Usually the parents come to us saying that their children are eating all day, but there is no weight gain and there is weight loss, and child is tired in the evening. So these are the major symptoms they come to us, and that should give a spark to you. I think there are many family physicians who are here who are also catering small children. So these are very important symptoms which you should not miss. There's all the flag signs. Now, what are the symptoms when there is complication of this type 1 diabetes? It is again the same as for type 2, blood vision, skin infection, slow healing wounds, numbness or tingling, and developing ketoacidosis. You know, blood vision is because if it is untreated, you develop retinopathy, neuropathy. So we all know about all these things. I'm not going to go into details about diabetic ketoacidosis. I'm sure you know what it is, why it happens, because when your body has too little of insulin to allow the sugar to enter in the cells, what does the body do? It takes energy from other sources, that is fats and muscles, muscle tissue and all, and the byproducts, they produce ketones. And the whole chemical balance in your body, that is acidosis. And what are the symptoms of diabetic ketosis? Because as Dr. Gargi said, sometimes the patient come to us straight away with the symptoms of diabetes ketoacidosis because they have not been diagnosed and the parents don't know that their child is suffering from type 1 diabetes. So there is breathlessness, extreme fatigue, abdominal pain, nausea and vomiting, confusion, and in severe cases, there is loss of consciousness and seizures. So now what should you do for this growth and development? Sometimes we find and we diagnose diabetes mellitus type 1 in as small as neonates, that is before 1 year. Before 1 year we find this, then we have the different stage. If you diagnose it before in 1 to 3 years of age, 3 to 10, adolescent and adult. Why I have distributed this? Because if you diagnose this before 1 year, you see sometimes children would come to you only with seizures. They have convulsions and the parents bring them. Usually the first thing when a pediatrician encounters convulsions or seizures below 5 years of age, we think of febrile convulsions, very common cause, or maybe epilepsy. But I think nowadays, we all pediatricians have a glucometer in our consulting. And the first thing we check when a child is having seizures is the blood sugar. I'm sure the same thing is happening in the general hospitals too, Dr. Gargi. So this is most important. And I think with all the doctors, even the general practitioners who are treating small children, kindly, if you find there is the child with a little or maybe loss of consciousness or seizures, please see to it that you do blood sugar of that child at that time with a glucometer, which I'm sure you people might be keeping in your clinics. So don't miss that. Why development is important in these small years? Because hyperglycemia, okay, but if the child has hypoglycemic attacks, because when it is not diagnosed, we see that children do tend to have more hypoglycemia because children have very irregular eating habits. In that case, this hypoglycemia is going to affect their growth of brain and physical growth too. So in that cases, the motor milestones are delayed, the growth is delayed. So it is very important that we don't miss these children with type 1 diabetes mellitus at this small, younger, sensitive age. So which are the domains of development we should think of? Physical domain, cognitive domain, and social and emotional domain. I'm not going to go into details of this, you all know, and all these domains are interconnected with the growth, overall growth of a child. So now, which is the most vulnerable group? Why adolescent group? Because when a child is small, they listen to you, they obey your orders. You want to give them insulin, they would silently sit down and take the insulin injection. Or if you control their diet, definitely they're going to listen to you. But as soon as they cross 10 years of age, I'm sure you all are parents and you know how tough it is to control our adolescent age group children. So they have all psychosocial problems and they also eat outside. They eat junk food. They have peer pressures. So it is the most vulnerable group to have control. So the risk of type 1 diabetes complications increases in this group, right? Why does it happen? Because one is insulin resistance. Sometimes if it is not taken properly, or maybe the dose is bad, the dose is not proper, because the parents, they don't go regularly to a doctor to adjust the dose. They don't even check their child's sugar every day, because they feel, why to prick a child every day? They are very much, I would say, they don't do it, they're afraid, and also they have all the conservations to do that. So we have to educate them. As Dr. Dhruvi said, the only thing to improve the cases of type 1 diabetes is education, education, education. And I think education of parents is most important, and then comes the education of the patient himself or herself. So then there is non-compliance. They don't want to take injections, because they don't understand the seriousness of what diabetes can do to their lifestyle. So we have to make them understand, educate them. What would happen if they don't take the treatment properly? Eating outside, snacking, eating fast food, how bad that can be. And career options. If they are going to go away from their house, if they are going to go out and stay in hostels, what would happen to them? How would they take insulin? How would they manage the dosage? So that all these things are very important at this adolescent age group. So along with the blood glucose control, what are the other things you have to take care when a child is growing up? Because only controlling the sugar is not an important thing. We have to think of that child as a whole. We have also to understand his needs and wants as he's growing up. He's going to become an adult. And this diabetes, we all know, is lifelong. And he has to tolerate that when he becomes an adult too. So we have to make him understand all the social situations when he's going out. What would happen to them if they're driving? What would happen if suddenly he gets an hypoglycemic episode, or a hypoglycemia, something? So we have to make him understand about all these things. Secondly, we have also to make him understand that he cannot take much alcohol, because yes, we are in Gujarat. We have, I think, still our kids are taking less alcohol, but in other parts of India, alcohol is the most common thing in the household. And when children become adults, 18 plus, they start taking it. So we have to make them understand how much they can take and how bad it could be if they overindulge into all these things, and what type of career they should plan if they're having a type 1 diabetes mellitus. So all these things need a lot of counseling and education in this children. So as I said, the transition is going to go there into adult group. And so we have to make them understand what would happen if they marry. They have, because this is a genetic disorder. So we have to make them understand. If it is a girl, we have to make her understand what would happen if she's going to conceive. So what should she do? Should she go and talk to the doctor first and then think about the planning, as we have already learned preconception, control of diabetes. So all these things are very important in childhood development of type 1 diabetes mellitus. This is most important. We still have a taboo of saying that I have diabetes, as we have taboo of so many other diseases. This is absolutely treatable disease. And I think a person who is suffering from diabetes, you should tell your patients, never have it in secrecy. You should be very frank, because this is just a part of your life. It's not going to make your whole personality. You yourself are a different person, and you should not be ashamed of having diabetes mellitus. And the person you're going to marry should also accept you with this disease. I think that is the best thing, because you should never hide such things. As we would not understand this, but yes, menstrual cycle do changes with sugar levels. It plays havoc sometimes in adolescent girls and maybe in adult females too. So we have to educate them for that too, because their doses have to be adjusted during menstruation. Again, as I already said, type 1 diabetes mellitus, growth and development itself is a huge subject. And I think it would take 3 hours or maybe more than that if I go into details of explaining. But as I have very less time, I'm just brushing up and giving you salient features. As you know, insulin requirement is different at different age group. We all know about that because your hormones go on changing. And with the growth, the dose of your insulin is also going to change. With onset of puberty, with all the surge of other hormones, the sexual hormones, the other growth, the motor, the muscle mass, your body mass is going to increase. And so is the level of the insulin you are going to take. It's going to increase. So we have to adjust and we have to make these people sensitized that you are going to change. Your dosage of insulin is going to change. You cannot take the same dose of insulin you are taking at 5 years and then when you become 15. It has to change every day. So now what can be done for this growth and development? Well, when this child comes to you, you have to see to it. It is our responsibilities, the responsibility of each and every medical professional to see that their patient does not falter into their growth. They should not have growth retardation. It is our duty. It is also our duty to see that psychosocial element. We have to make them, as Dr. Dhruvi said, we have to find out some time, counsel them, make them easy with this disease. Not only the patient, but the parents too, the family too. Let them take it so easily. If they are going to take it easily, the child is also going to do that. As we saw in this video, the small girl was so easy with her. She said, I'm taking the insulin twice and I'm fine. I'm playing. Yes. Make them understand that this is not a disease which would have limitations in their life. But if they have been taking proper treatment, they can lead absolutely normal life. Right? So what can go wrong if it is untreated or undiagnostic? Well, we all know that you will have poor height and weight gain, that's fine. But there would be haywire in thyroid functions, renal functions, hemogram. Sometimes there is obesity and all these eating disorders and all. Will not go into details. So what we should check? We should check all these things, height, weight, blood pressure, if the patient comes to you. And of course, the growth velocity is very important for any patient. If you catch them young, their growth velocity has to be charted out by every doctor when a child is growing with you. With humans, they are coming regularly to you with this disease. Now, what does happen if there is a improper growth? There is a vicious cycle. They have poor self-esteem. There are so many other complications. And with that, when they grow up, there is problem of employment, income, psychosocial problems. They have problems in their marriage. So many things occur. So we don't want our patient to suffer from all these things just because the poor child could not be treated as a whole for type 1 diabetes mellitus and she or he has come to us. Okay, so it is very important for us to see that we focus on growth, not only physical, but mental aspect of every type 1 diabetes. You know, these are the celebrities. We all know them. And they had that, they have type 1 diabetes, and you know, they have been on the top. The middle lady, she was an Oscar winner. She's an actress. And see, if they can live a normal life, why can't our patients, our kids who are suffering from type 1 diabetes? Okay, so our goal for care should be optimum growth and pubertal development for a kid of type 1 diabetes who comes early to us, who's been diagnosed by us at an early age. And we should not miss a single patient when they come to us. So this type 1 diabetes, I would say, is like an iceberg. So many things still have to be done in this. Even the government needs to do so many things because we are talking about urban development in rural areas, in all the far villages. This type of type 1 diabetes children are being missed, and they are, as Dr. Dhruvi said, been diagnosed in an adult age. So I think it's like an iceberg, and I'm sure slowly we will try to venture into this and increase the scenario, or I think improve the scenario of diagnosing and treating type 1 diabetes mellitus. Thank you so much for a patient hearing, and thanks for giving me this opportunity.
Thank you, Dr. Monaman, for explaining such a nicely regarding the type 1 diabetes. And now actually it is our duty to explain not only the patient, but to the parents and to the society also, that we have to accept the situation. We should not run away from that. Thank you so much. Okay, now let us proceed for our third session. I would like to introduce Dr. J.P. Sai. He is a senior consultant diabetologist at Apollo Sugar Clinics, Hyderabad. He has received the Diabetes Awareness Initiative Award from Bangalore from USV India Limited. He is a member of IMA and RSSDI and EASD. He has won the awards from the Appreciation Award from Rotary Club of Hyderabad Center 2009. He is EC member of RSSDI. He is a Diabetes Awareness Initiative Award Bangalore by USV India Limited 2014. And he is a medical advisor board Apollo Sugar Clinics Limited in 2015. So with the short introduction, I would like to invite Dr. J.P. Sai. Thank you.
Good afternoon. Special thanks to chairperson, and after two excellent speakers, Dr. Dhruvi and Dr. Mona Desai. It's very difficult from Hyderabad to speak. And I am really impressed with Rudraksha Institute of Medical Sciences under leadership of Dr. Dhruvi and Dr. Vipul. They are doing an excellent work in the field of diabetes. And actually, Dr. Dhruvi gave an excellent talk on type 1 diabetes. And I was impressed with a girl child saying that she takes insulin and monitoring, and she enjoys her regular activities, games, and diet. I think empathy, diabetes care, education is very important in diabetes care. And we know there are a lot of unmet needs, the new approaches to manage diabetes in children. And we know that we currently have insulin pump therapy, but artificial pancreas is basically a small portable medical device designed to carry out the function of a healthy pancreas in controlling blood glucose levels using digital technology, because it automates insulin delivery. The system basically is one external on the body, and it's made up of three functional components: a glucose sensor, a computer algorithm to calculate the insulin dose, and an insulin pump. We know that basically the challenges of type 1 diabetes in children is that each day and night there is insulin needs vary. The solution for having a artificial pancreas or a closed loop system is that it is designed to automatically adjust insulin delivery based on sensor data, thereby helping patients stay in target glucose range. We know that there is a lot of discussion on timing range. So basically, the closed loop system automates and auto-corrects dosing, helps keep the patient glucose in target range. And early intervention is key, because for a type 1 diabetic in children, for managing control, it takes a long period. And if you have an early intervention and the automated insulin delivery system basically helps, because we know the challenges of correction boluses can trigger hypoglycemia in case insulin dose is not calculated properly. In closed loop system, it is designed to deliver auto correction boluses early and automatically to reduce the risk of high and low glucose swings. And we know that there is a lot of mealtime announcement and prandial insulin boluses are carried out by patients. This overcomes the delay in insulin action of currently available insulin analogs administered subcutaneously. And this automated insulin delivery device will minimize this risk of hypo and hyperglycemia. And if you see, there are latest studies from the Cambridge closed loop insulin delivery system has shown that they have seen for 6 months of use of this artificial pancreas, they have seen a very drastic improvement in glycemic control. And they have seen day and night of use of this closed loop system helps in managing diabetes control better in children. And there is one more study in do-it-yourself artificial pancreas system also has shown very good results of using AP. So we know that technology for diabetes management is rapidly developing and changing with each new developments. There are numerous factors to consider. We know that we should see that the medical benefits and its impact on quality of life and ease of use and barriers to use. And with this development of automated algorithms, and it can improve the glycemic control, and it also helps in basically type 1 diabetic children has different behavioral and physical activity, and it is important point in reaching an optimal metabolic control because of using automated insulin delivery device basically helps in reducing the glycemic excursions. So the current challenge is that in future we may see artificial pancreas. I think by the end of this year we may get Minimed from Medtronic 780G system, which is approved by FDA. We may receive that, and we will see more insights of using of this artificial pancreas in many children. Maybe it may also help us to understand the fluctuations of blood sugar and the technology aspect of that and the sensors. We know that there is a Dexcom G6 glucose sensor, and Medtronic also has a Guardian system sensors. So this will overall help us also for a better management of diabetes, because we know that type 1 diabetes in children is a complex because it needs a holistic approach, as Dr. Dhruvi was clearly mentioned in a lecture that type 1 diabetes management in children is a very complex, and it needs a whole team work is very important. Thank you. I just want to give a brief note on artificial pancreas.
Thank you, Dr. Sai, for the very nice explanation. Now, next session.
Thank you, Sai sir, for being present and spreading light on artificial pancreas. Very quickly, do we have any questions on pediatric diabetes, or for Mona madam, for Sai sir, or for myself, for the faculties who have joined us online as well?
One question for me.
Yes,
what should be the follow-up checkup of the neonates of one gestational diabetes mother and the one and second is a type 1 diabetes mother?
All right. So, Sai sir, do you want to take it up? We have a pediatrician, Mona ma'am. Do you want to take it up? I'll give you the mic.
Hello. Yes. If the mother is having gestational diabetes, usually when they come to us, we are very skeptical because she's breastfeeding the baby. And as already been said, that if she's on metformin or something, it crosses the placental barrier. So there are so many times, because with gestational diabetes, we all know they deliver big babies. Usually they are 4 kg plus babies. So they tend to go into hypoglycemia very fast. So we have to be very careful as a neonatologist that this hypoglycemia does not occur, because otherwise the child would have seizures within first 6 hours. So the first thing, early feeding has to be started. Of course, mother cannot give breastfeeding within first 6 hours naturally, because she has just delivered the baby. Yes, we do let the child suck the mother, but sometimes we have to give child glucose water or maybe start with a formula feed. So the feeding has to be started very early in these children. And we have to see that they don't go into hypoglycemia. And the signs of these children going into hypoglycemia is lethargy. They become very lethargic, or there is irritable crying. There is irritability. So we have to be very careful, and blood sugar, yes, is measured in this neonates. So this is what you have to be very careful for first full 7 days in a neonate.
Thank you, ma'am. Sai sir, any comments? Ma'am just talked
Yeah, I
about.
agree with that, ma'am.
hyperglycemia monitoring in neonates. Any comments you want to add for already type 1 diabetic person? How frequent should be our screening for kids with type 1 diabetes?
So for the type 1 DM, yeah. Mother.
Yeah, for type 1 diabetes.
Dhruvi, can you come back again?
How frequent should be our screening for a child who is not a diabetic and for a child who's already a type 1 diabetic? How frequently should we be screening them? Right, Dhiren sir, that was your question. Yeah, that was the question, Science sir.
I think we should regularly screen. I think
I'll take it up. Dhiren sir, first, for a child who is not a diabetic, it is the pediatrician again who brings it to the light. There will be growth retardation. Like ma'am said, for a neonate, there will be irritability, there will be lethargy, and it is the pediatrician who will come to the terms that, this is the child that needs to be screened for hyperglycemia. For a mother who was just going through gestational diabetes or pre-gestational diabetes at the time of birth, it is now very, very apparent, and the guidelines are saying that you have to test them for an RBS. If that RBS, if the screening is showing hypo or hyper, then the pediatrician takes care accordingly. But after that, again at 6 months, the pediatrician will test again for an RBS. Again at 1 year, the pediatrician will test again. If, depending on what kind of an RBS value the child is showing, according to that, they will either refer it out to a diabetologist and they work in a team. For somebody who's already a type 1 diabetic, now there is a neonatal diabetes, which if is detected before 9 months of age, sometimes it goes away. There is a transient neonatal diabetes, and for somebody for the child, when it is the hyperglycemia prolongs and is converted into an actual full-fledged type 1 diabetes, for them the screening, again, monitoring needs to be done at an ambulatory case as well. The parents have to be checking, have to be monitoring. The more the monitoring, the better. For them to be asking the patient to visit to our clinic, it is monthly, because you want to address the growth factors, you want to address how the child is feeding, you want to address कि कितना growth हो रहा है, what are the other developmental milestones that the child is achieving. Again, the role of a pediatrician comes into very, very high importance, because that is the time the parents will take the child to a pediatrician and not to a diabetologist. As diabetologists, what we say is a home ambulatory blood sugar monitoring for an already type 1 diabetic kid. For age below 5 years, the targets have been set that it can be somewhere between 100 and 180. We are a little lenient. For somebody who's above 5 years of age, we are a little bit stringent, below 160. Somewhere between 80 and 160, the ISPAD is stating guidelines according to age. And again, we are somebody who are concentrating on numbers more than the growth and development of child, but that's what should not be done. Screening, again, for an adult child, post-pubertal child, screening is every month. If the sugars are normal, once in 3 months. I think it was a little 11. Thank you, sir. Thank you. With that, we'll close the session. We do have a message from the International Society of Pediatric and Adolescent Diabetes, Dr. Karen Debefoe. She's from Luxembourg, and we have her video, but we are not going to play it right now because of lack of time. We'll play it in the end, and we'll move on to the next session. But before that, I'm going to request our chairpersons to felicitate our... Oh, yeah, there has to be. Sir, do you want to take it up? I'm sorry, I forgot. Do you want to take up any question for the audience? All right. I know, I was the one preparing. All right. I'll very quickly ask from one in the audience. Yes, sir? I'll very quickly ask one question to the audience. What do you think should be the target for HbA1c for a post-pubertal and adolescent, teenage boy or a girl? What should be our glycemic target? If you can have a number, I'll give you options: below 8, below 7.5, below 7, below 6.5. The chairperson should be choosing the audience rather than me. No, the answer is below 7.5. Sir is correct. We're not so strict with adolescents. Adolescents, it's not possible with adolescents to get a very strict control. The important point is that we get their growth and development, their sexual characteristics, secondary sexual characteristics more than the glycemic control. So, sir is the winner. And with that, I will request our chairpersons to felicitate our faculty, Dr. Mona Desai, ma'am, for wonderfully talking about growth and development in type 1 kids. Do we have Dr. Nidhi Patel in the room? Can I request Dr. Nidhi Patel, ma'am? She's an ophthalmologist. Can she help me felicitate our chairperson, Dr. Gargi, ma'am? Gargi, ma'am, has been really, really vibrant, adding on to the life of the session. Thank you, ma'am. Please, ma'am. Nidhi, ma'am, is an ophthalmologist. Thank you for felicitating our chairperson, Dr. Gargi Patel, ma'am. Can I request Ghadvi sir to honor and felicitate our chairperson, Honorable Secretary, Dr. Dhiren Mehta sir, please? We need to have both of you in the same frame. President to Secretary, yes, sir. From the President of Ahmedabad Medical Association to the Honorable Secretary of Ahmedabad Medical Association. Thank you so much for chairing the session, sir. Sai sir, we'll be sending you your memento soon. Thank you for connecting with us online.
Thank you.
Facilitated by we'll take a
Thank
selfie. All right, with that, we move on to our next session very quickly, our groundbreaking advances in diabetes. And for that, I'm going to invite our chairpersons, a very well-known infectionist, Dr. Vipul Shah sir, and Dr. Sanjay Shah sir, who's a leading family physician from Maninagar. We have all our faculties eagerly waiting to deliver their lectures. We are apologizing for the delay. I would request the chairpersons to introduce our first speaker.
Good afternoon, and first of all, I congratulate Dr. Dhruvi and Dr. Vipul for arranging such a nice diabetes update. We start our fourth session, and that is advancement in diabetes. And for this, I invite first Dr. Pratap Jethwani. He will be live from Rajkot, and it is my pride to introduce him. I think Dr. Pratap Jethwani doesn't require any introduction for those who are interested in learning diabetes. Dr. Pratap Jethwani is a fellow of RSSDI and Diabetes India. He is honorary secretary of Gujarat chapter of RSSDI and very much interested in learning for those who are interested in diabetes. With this introduction, I invite Dr. Pratap Jethwani. He is going to talk on subject SGLT2 inhibitor.
Thank you very much for kind introduction. And let me first begin by thanking Dr. Vipul Chawda, Dr. Dhruvi, RIMS, and Ahmedabad Medical Association for inviting me to speak on SGLT2 inhibitors. I hope my screen is visible.
Yes. Yes, it's visible.
So I will be talking about SGLT2 inhibitors, although it is a very wide subject, but I will be trying my best to sum up all the information related to SGLT2 inhibitors in 10 minutes time. So we all know in normal healthy individuals, no glucose is passed in the urine. Whenever you test urine sugar, it is absent, and that is because of glucose reabsorption taking place in the proximal convoluted tubule. So whatever glucose is filtered is reabsorbed, and that is there also in type 2 diabetic patients, contributing to hyperglycemia. And there is a novel way of now we have got new drugs which block this glucose reabsorption taking place in the proximal convoluted tubule. So there are two enzymes, mainly SGLT2 and SGLT1, The SGLT2, it contributes to almost 85% of glucose reabsorption from the proximal convoluted tubule. So if we block this enzyme, then the glucose will not be reabsorbed. It will pass in the urine. There will be glycosuria, and that will contribute to reduction in blood glucose values that is there in type 2 diabetes patients. So this is a novel way of reducing blood glucose by increasing glucose excretion in the urine with the help of this novel class of drugs that is being termed as SGLT2 inhibitors or glipizins. Now what happens when the glucose is excreted in the urine? Apart from reduction in blood glucose and benefit in glycemia, as glucose carries a lot of calories, that is 4 calories per 1 gram, and SGLT2 inhibitors, they result in approximately 75 gram of glucose excretion per day. That will translate into loss of around 300 calories, and that will result in a weight loss. So these drugs are the drugs which, apart from providing glycemic control, they result in weight loss. And because of glucose excretion in the urine, there will be osmotic diuresis, there will be natriuresis, which will result in reduction in plasma volume, and all this that will contribute also to a reduction in blood pressure. So the three important comorbidities which our type 2 diabetic patients they are having, that is high blood sugar, high body weight, as well as high blood pressure. All these three things can be touched upon with the help of SGLT2 inhibitors. Apart from this, these are the various benefits which are highlighted here, which are there with SGLT2 inhibitors when they are used in a routine clinical practice. I will touch upon some of these aspects in my subsequent presentation. So these are the glipizins, that is dapagliflozin, empagliflozin, and canagliflozin, which are there available in our market, and rest are coming in near future. So this is about glycemic efficacy. They will reduce HbA1c to the tune of 1%, and there is now evidence to support that they are more efficacious in Asians as compared to white population. So we respond much better to SGLT2 inhibitors as evident from this graphics. At the same time, they do not increase risk of hypoglycemia because they do not touch upon insulin. So they have got a very beautiful insulin independent mechanism of action, and because of that they can be used across the spectrum of type 2 diabetes, be it early diabetes or a very light diabetes. When the patient is on multiple insulin injection therapies, you can use these agents because they do not require insulin to be effective, and because of that also they do not increase the risk of hypoglycemia. This is in comparison to sulfonylureas. They provide same HbA1c reduction, but the risk of hypoglycemia is rather minimal or negligible. As I have already highlighted, they are associated with a weight loss of around 2.5 to 3 kg, which is an important extra glycemic benefit of these molecules. And this is mainly because of a loss of fat mass, and that is mainly from the ectopic sites. So from the abdomen, from the muscle, from the liver, everywhere else, the ectopic fat is there in an obese person. That will be lost with the help of SGLT2 inhibitors. And because of that, these are the beautiful molecules that act upon various aspects in a type 2 diabetic patient. Blood pressure reduction is there, whether you use a clinic blood pressure measurement, home blood pressure measurement, or ABPM. There is a reduction in blood pressure, whether you take it morning, evening, or nocturnal. There is a reduction in systolic blood pressure to the tune of 5 to 6 millimeter of mercury, and in diastolic blood pressure to the tune of 2 to 3 millimeter of mercury. And that is because of multiple actions which are there. Apart from weight loss, diuresis, natriuresis, there is some ketogenic activity, there is some direct effects on the arterial blood wall, arterial stiffness decreases, and all this they contribute to this blood pressure reduction, which is evident with SGLT2 inhibitors. They have got effects on body lipids also. The reduced triglycerides, the increased HDL cholesterol. At the same time, they increase LDL cholesterol also, but the increase is mainly in the large particles of LDL cholesterol, and the small dense LDL cholesterol decreases. As these agents, they result in reduction in blood glucose. At the same time, they reduce insulin release from the pancreas, and there is a marginal reciprocal increase in glucagon secretion, which will contribute to the formation of ketones. So mild increase in serum ketones will be there with these agents, and which probably provide some of the cardiovascular benefits which are seen with these agents in clinical practice. There is a reduction in uric acid also, as evident from this graph, and this is to the tune of around 45 micromole per liter, and this is evident with all the SGLT2 inhibitors which are there in the market. Now, why these agents are discussed so much? Because they not only provide these benefits in blood sugar, body weight, blood pressure, uric acid, and lipids, but that translates into a cardio-renal benefits for our type 2 diabetic patients. So the EMPA-REG was the trial which first established that an anti-diabetic drug can provide cardio-renal benefits or cardiovascular benefits on the top of glycemic efficacy, and it changed the way we look upon the anti-diabetic agents which are being used in type 2 diabetes. There was a reduction in 3-point MACE by 14%, CV death by 38%, and total mortality by 32%. And that was later on translated into various other trials, that is Canvas trial, Declare, TRIMI, Credence, and now we have got a plethora of trials related to SGLT2 inhibitors, all confirming the same, that they provide cardiovascular benefits, and that is mainly by driving the reduction in heart failure hospitalization, which is the core that is being addressed with the help of SGLT2 inhibitors. There is also a renal benefit. They reduce the risk of progression of chronic renal disease. The patients on these molecules, the renal disease progresses slowly. The risk of requirement of renal replacement therapy decreases. The risk of renal death decreases. Also, the risk of cardiovascular events, which are very much common in these people who are having chronic kidney disease, goes down. So with single drug, you can provide both cardiovascular benefits as well as renal benefits in your type 2 diabetic patients who are having chronic kidney disease. And this is the reason why most of the guidelines now, they endorse either presence of atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease as a compelling indication to prescribe SGLT2 inhibitor for type 2 diabetic patients. That means if you have got a patient in your clinic who is having type 2 diabetes and who is either having established atherosclerotic cardiovascular disease or chronic heart failure or chronic kidney disease, then you have to give them SGLT2 inhibitor irrespective of HbA1c level. Even if their HbA1c, if they are having very good control of sugar, still you have to give them SGLT2 inhibitors, because it is not for glycemic efficacy, it is for cardio-renal protection which is being imparted by these molecules, and that's why you have to use these molecules in this kind of patients. And apart from this, there is a benefit in NAFLD and NASH also. It decreases hepatic fat, and there is evidence to support that from Indian study also. So type 2 diabetes, a lot of people are having fatty liver, NAFLD, NASH. These drugs, they also touch upon the reduced ectopic fat which is there in the liver, and that translates into reduction in hepatic inflammation and probably in hepatic fibrosis also. Also, they reduce obstructive sleep apnea also, as evident from this data from EMPA-REG trial, and this is a new area of research with these molecules. It has got a beneficial effect on retinopathy also, although not statistically significant from this EMPA-REG, but definitely it has got some beneficial effect on retinopathy also. Now I will just touch upon the side effects profile of these molecules. They are quite safe if they are used judiciously in our type 2 diabetic patients. The only problem is about genital mycotic infections, which is increased. So you have to counsel your patients about two things. First is hydration, and second is genital hygiene. Most of the time, genital mycotic infections, they are mild and they respond well to treatment. But if there are recurrent genital mycotic infections, one may think of stopping these agents or not using this kind of patients. As far as UTI is concerned, there is a reassuring evidence from randomized control trials as well as real world studies that these agents, they do not increase the risk of UTI. But particularly in our clinical practice, we see many type 2 diabetic females. There is a small group of patients who are having chronic UTI. I think in those cases, we are not justified to use these agents because they promote glycosuria, and we all know that the glycosuria will increase the risk of both UTI as well as genital mycotic infections. all other issues which were there, concerns about SGLT2 inhibitors in past, like fracture risk and amputation risk. I think currently there is no substantial evidence to support this side effects of SGLT2 inhibitors, but there is a very important side effect of SGLT2 inhibitor, and that is euglycemic diabetic ketoacidosis. So people who are not taking orally properly, and if they are on SGLT2 inhibitors, then there is an increase in the risk of euglycemic diabetic ketoacidosis. And that's why this agent should not be used during an acute illness. And also anybody who is requiring a planned procedure, this agent should be stopped at least 48 hours before that planned procedure, which requires nil by mouth for that procedure. So that these are the few things which one should keep in mind while using these molecules in type 2 diabetes patients. To summarize, I will say SGLT2 inhibitors, they have changed the way we treat our type 2 diabetic patients. They have got a lot of benefits, starting from blood sugar reduction to blood pressure reduction to body weight reduction, reduction in uric acid, as well as improvement in dyslipidemia. There are improvement in hepatic fat content, NAFLD, and multiple other extra glycemic benefits which are there. And these are the variety of mechanisms by which they contribute to that cardiovascular, renal, and metabolic benefits which are being provided by SGLT2 inhibitors. And I think these molecules are going to be the first line or first add-on to metformin in near future in all our type 2 diabetic patients. With that, I end my presentation. I hope I have completed my presentation in 10 or 12 minutes time. And I welcome you all to join hands together to support our Defeat Diabetes campaign by RSSDI. Already Dr. Bansi Sabu, president of RSSDI, has talked about it. So we all, let us join to our hands together to defeat diabetes in our country. Thank you. Thank you very much.
Thank you, Dr. Pratap Bhai. You have very well narrated the use of SGLT2, and after the reduction of cost in SGLT2 inhibitor, it is well accepted also. Now I request Dr. Vipul Bhai to invite second speaker.
Very good afternoon to all. Thanks to the Dr. Vipul for inviting us as a chairman, for the chairperson for this session. The next talk is on peptide in a pill. The peptides represent $1 billion market in the pharmaceutical industry, but they can generally only be taken as injections to avoid the degradation by stomach enzymes. The scientists now develop a method to generate peptides that resist the enzymatic degradation in stomach, and that can be taken orally. So, and today Dr. Vijay Patni is going to throw the light on this peptide in the management of diabetes. So I welcome Dr. Vijay Patni. Just introducing him, he's a head of the department, Diabetes Wellness Care, visiting consultant at DM Birla Heart Research Institute. He is a founder, Diabetes Research and Welfare Association. He is organizing secretary and scientific chairperson of annual conference of DRWA since 2014. He is a regular faculty at various local and national symposiums. He has contributed various publications in scientific journals. He is a life member of various August associations. He is from Calcutta and is going to talk live online. Dr. Vijay Patni.
Thank you. Am I audible and visible?
Yeah, you are audible and visible.
Just. Okay. Thank you, Dr. Vipul and Dr. Dhruvi and the whole team of RIMS for the kind invitation. Okay, so obviously it's a 10-minute talk and no fringes attached. So basically I go straight to the topic. And as we have already heard from Dr. Jetwani about the SGLT2 inhibitors, they have been ruling the roast basically for the last 5 years. Now we have this blockbuster drug probably which will be coming sometime this year, end of this year. And this is about the oral semaglutide. So we will go through this particular agenda. Is the screen moving? Yeah. Fine. So all of us expect something from the anti-diabetic drugs. What we actually expect is that we do expect that we need to have a good glycemic control, but along with that, obviously the off-target effect should be minimum. We need to achieve that with least of weight gain and hypoglycemia. So where do we stand as far as SGLT2 is concerned? GLP-1 receptor agonist is concerned. Now we all are aware of the omnious octet, about 8 of them, and if we look into the GLP-1 pathophysiology, basically 6 out of 8 are being tackled by GLP-1 receptor agonist in our human body. And if you look at the various organs where it's low, that's at the liver, it's obviously decreases the hepatic glucose production, increases the hepatic insulin sensitivity. It decreases the de novo lipogenesis and decreases steatosis. Heart, it has the cardioprotection, vascular protection. Brain obviously increases satiety. Pancreas, it decreases the glucagon, increases the beta cells, increases insulin bars, along with GI tract, decreases the gastric emptying. The natriuresis, which is there, increased in kidneys and increased nephroprotection, which we see along with the increased insulin sensitivity. So you just look at these various effects of the GLP-1 receptor, and it becomes a truly great molecule whenever we try to consider any anti-glycemic agent for any of our individual diabetic population. But what was the problem? The problem, we know about these molecules, they have been there since 2015, and we have been using it, but most of them were injectable. And now the whole scenario has changed. The innovations in medical sciences have helped us over the last decade or so to not only help us in delivery systems, but also come with little recent innovations and various other mechanisms so that we can overcome the various barriers which are associated with the therapies. So the unmet need obviously was, particularly considering our population, was obviously the injectable part, the GLP-1. Now, if you can address that particular barrier, probably we are able to increase the compliance as well as expand the treatment options. You will have a better outcome, and the convenience and the mode of therapy, obviously, all are going to increase. So there will be a rationale for oral delivery of peptides. Our chairperson has already said peptide means a big issue. You just can't give a peptide in a pill and can get away with it because it has its own unique challenges. The challenges obviously happens to be there. Enzymatic degradation, which can occur in the stomach, which will, with the help of proteolytic enzymes, there could be limited permeability across the gastrointestinal epithelium, and along with that, obviously, that will lead to low bioavailability, and the bioavailability is so low that probably is not going to really work. So you just can't give a peptide in a pill and then expect the result which is expected of any molecule. So the quest for the first ever oral GLP-1 receptor agonist started, and the science and innovation has definitely helped it, and we have been able to achieve it by what we know is that we have, just because we are not sure about the one such GLP-1 receptor agonist, that semaglutide, which is probably the one GLP-1 receptor agonist, which is 94% homologous with the native GLP-1. Here, what they do is that they combine the semaglutide with the absorption enhancer, which is a SNAC. And this combination will help us, the semaglutide, absorb across the gastric epithelium and thereby increase the oral bioavailability. So this is the changes which has occurred. This is the various innovation which have taken care by this particular, by the innovation is going on this particular molecule. As a result, the possibility of an oral peptide was there. And along with that, if you see that this co-formulation with absorption enhancer SNAC was able to help this pill to be bound in a peptide, this peptide to be bound in a pill form. Now, this oral semaglutide has undergone huge trials, clinical trials, 24 clinical pharmacological trials, 1 phase 2 trial, and 10 pioneer 3A trials. So about 9,500 subjects enrolled. Out of these, 5,700 were given exposed to oral semaglutide, and you have whole data with it. So the clinical trials are great pointer towards the efficacy and the vitality with this particular molecule, what we could see. And there are the whole 3A clinical program, which is the pioneer program, right from pioneer 1 to pioneer 10. So you can see the various comparators and the various scenario in which this molecule was used in the clinical program. Pioneer 1 was for vis-a-vis placebo along with diet and exercise, whereas as an add-on to OAD, the Pioneer 2, 3, 4, and 7, whichever molecule choose SGL2, DPP4, or GLP-1 receptor agonist, or a flexible dosage vis-a-vis DPP4 inhibitors. And then you have this comparison with the Pioneer 8 with insulin. Along with that, you have these Japanese trials 9 and 10, which were particularly with only in Japanese subjects, liraglutide and liraglutide. And the most important part of this is the CBOT trial, that is the Pioneer 6. Pioneer 6 actually, along with the injectable semaglutide Sustain 6, gave whole lot of importance to this particular molecule GLP-1 receptor agonist semaglutide. And the ongoing trial which we have is the superiority CBOT trial, that is the sole trial, where the results will be due in next 4 years, where we have lots of Indian subjects enrolled in this particular program. So if you look at the major targets, that is HbA1c and body weight, you will appreciate from various other programs, that is Pioneer 1 to Pioneer 8, that the HbA1c reduction was great up to the extent of 1.5, whereas the change in weight was up to the extent of 5 kgs. None of the drug, whichever you have right now, are metrium, basically, does it have such a huge impact. And these are in comparison to almost all the standard of care molecules which are available in the management of type 2 diabetes. So across the global Pioneer trials, what we could see that oral semaglutide achieved a good HbA1c reduction up to 1.5%, and the weight reduction was seen up to 5 kgs. Similarly, if you look at the post hoc analysis, what we realized from Pioneer 1 to Pioneer 8, basically, that with a baseline of more than 9%, you could achieve a reduction of 2.6%. I mean, no other molecule, even insulin, we cannot achieve the HbA1c of more than 2.5% reduction without incorporating the element of hypoglycemia. So here you have a molecule which showed that with HbA1c of more than 9%, probably you will be able to have HbA1c reduction of up to 2.5% reduction. And that was used. If you add on to the other endpoints like weight and your along with the weight loss, then it becomes a great molecule to talk about. Now let's look at the CBOT trial with the oral semaglutide. That is the Pioneer 6. What was it all about? The population which was taken into consideration was 50 years old with established diabetes or 60 years old with one of the CV risk factors. There was a good retention rate and follow-up. And then there was a 3-point MACE which were looked into. And what we could achieve was a 21% non-significant risk reduction vis-a-vis placebo, along with the usual benefits of HbA1c and body weight reduction. So from this CBOT trial, we could conclude that it is cardio safe, and there was a good non-significant risk reduction up to the extent of 21%. Now, if you look into the injectable semaglutide CBOT data, that is from the Sustain trial, where it showed the superiority, because there was only basically that there was a difference as far as the studies were concerned. That was the reason why we got the superiority in the Sustain 6 trial, where we could not get that in the Pioneer 6 trial. So along with that, the efficacy outcome as far as the observed HbA1c is concerned or observed body weight reduction is concerned, you will all appreciate that they decrease more in the semaglutide arm than in the placebo arm. So even there was more use of concomitant anti-diabetic medication in the placebo arm compared to the oral semaglutide. So Pioneer 6 has definitely stamped its authority as far as semaglutide, oral semaglutide is concerned, in order to achieve its efficacious target of HbA1c reduction as well as body weight reduction. Now let's combine both Sustain and Pioneer. If we both combine together, then you'll see the consistent effect on the MACE with 24% risk reduction versus comparative across varying severity. So if you take Pioneer as such all alone, then it has a 21% reduction. Then Sustain 6, it has about 26% risk reduction, which was superior as well. And when you combine these two, Pioneer 6 and Sustain 6, even though they had the similar hazard ratio, they were pioneers could not satisfy it because of the difference in study design. But both taken together gives us an inkling of thought that probably what we are going to see in the future superiority CVOT trial might be going the same way as sulfate semaglutide. So that we can keep hope on, and we might be able to talk about it a little later sometime in the next few years. So to summarize of the phase 3 oral semaglutide pioneer 1 to 8, obviously you can all appreciate that it has a higher HbA1c reduction in comparison to empagliflozin and sitagliptin. They were non-inferior to liraglutide. As far as weight reduction is compared, it was better off in comparison to sitagliptin, liraglutide, though it was not very significant as far as empagliflozin. So oral semaglutide definitely demonstrated a significant greater HbA1c and weight reduction vis-a-vis the sitagliptin and liraglutide. And what we can confirm from the cardiovascular safety trial, that is cardio-safe, though there is along with non-significant reduction in MACE as well. So overall, it looks safe, well tolerated with a good safety profile consistent with most of the GLP-1 receptor agonist class. Obviously, the side effects remain similar to what other GLP-1 receptor agonist has. So efficacy was established when given early in therapy or late or with regard to hepatic or renal status of the individual. So a combination data will add to the overall CV evidence of semaglutide. Obviously, we are looking at the SOLVE because of the superiority trial, which is going to encompass on the cardiovascular outcome of oral semaglutide, and that is where we are going to look into. Though it is going to look into the renal outcome as well as the peripheral artery disease as well, and along with the various other trials expected over the next few years. So not only the mechanism of action will be looking into both the cardiovascular, renal as well as the peripheral artery trial, but more importantly, the SOUL trial is going to provide the soul into the whole molecule of oral semaglutide. Now let's go into this important aspect of oral semaglutide, because this is very important, and this is everyone need to practice, because we expecting this molecule sometime end of the year. That how it should be administered. As soon as you wake up, you take the tablets, and with about half a glass of water, and then for half an hour, you're not going to eat anything, drink, or take any other oral medication. So there is a question, obviously, because we always take Altroxin or the thyroid tablet as an early tablet, even at the bed, when you're getting up from the bed. So it's very important you take semaglutide and give a period of half an hour to 40 minutes before you take any other medicine, including thyroid. So that's important. So have your first meal and drink of the day and take any other medication you need only after 30 to 40 minutes of your semaglutide tablets. So you start with always with a smaller dose of 3 milligram, but always tell the patient that it's not the dose which we are probably contemplating for management of your type 2 diabetes. We are initiating so that if the adverse effects check, and thereafter every 4 weeks we can increase it to 7 to 14 milligram, which is the optimized dose on which most of the studies are based on. So advise the patient that if you miss a dose, they should skip the dose and take the next dose, the schedule, the next dose. Now, where do we really place this particular molecule? As we place most of the GLP-1 receptor agonists, we are aware of this. Most of the guidelines and the guidelines have already dictated where to place the GLP-1 receptor agonist. But this oral semaglutide doesn't have a positive CVOT trial. So what are the concerns and where can we place it? But still you have lots of, there are a whole lot of potentiality where you can always live. Whenever you have an issue with your HbA1c control or weight control, obviously this oral semaglutide has a great chance of being introduced because it has a huge 5 kg weight reduction, what we have seen, and a 1.5% HbA1c reduction. Now, if you have a CVOT, atherosclerotic CVD or a CV risk factor, at least it doesn't increase the CV risk, so it can always be added to the standard of care therapy. Along with that, there is no restriction for oral semaglutide regardless of renal function, so it can be recommended for end-stage renal disease. And obviously, whenever you're trying to combine with any other drug, including insulin dosage, it has been seen that the insulin dosage do decrease when you combine an oral semaglutide. So you are able to achieve not only your glycemic targets, your weight targets, your probably the dosage of insulin definitely decreases, and along with that, as because it is more or less CV stave, it can be given in population who has CV risk factors. So when would you can consider use of oral semaglutide? It can be considered across the clinical scenario, whether they don't have to be in a specific patient characteristic. Wherever there is an issue of hypoglycemia, wherever there is use of hepatic impairment, where there is issue of renal impairment or weight loss need to be added problem for an individual, and along with that, any older patient, because it does not affect the efficacy safety of the oral semaglutide at any age. So if you see, this is a drug which can be given in any scenario at every part of the management of type 2 diabetes. So it looks like a blockbuster drug in the future, and obviously the cost factor and all those stuff will definitely come. We have seen the SGLT2 reigning for last 4-5 years, and add on to that SGLT2, this GLP-1 subtagonist, oral particularly, because the adherence, the compliance, and whatever we can achieve can always be better with the oral kind of preparation. This drug looks good in future. So if you look at the practical algorithm, particularly switching over is important because this is what you are going to expect from your patients. As soon as the drugs are available and patients are aware of that the oral GLP-1 is available, then they will definitely want to switch from the injectable one to the oral formulation. And here, what you can do, if you have once weekly injectable, you can always wait for a week and thereafter introduce this oral drug. And if you are using a once daily injectable, then you can first dose administered the following day after discontinuation of the injectable. So these are very important. If the switch is only promoted by the GI side effects, then you always wait for the symptoms to resolve, start with a lower dose, titrate it up, and then come to the maintenance dose. So those are the important factors which one need to look while switching over from injectable to oral semaglutide. So obviously, you have to keep the side effects profile into your consideration. Adequate titration is important, and the glycemic response can only be viewed when you optimize the dose to the maximum. And these are the various agents. This is how the equivalent dose will qualify for oral semaglutide, whichever injectable you are using. Dulaglutide 0.75 milligram can be substituted for 7 milligram of oral semaglutide, and similarly you can do it. So most important, the first dose of 7 to 14 milligram to get administered 1 to 7 days after the last injection. So that's important. So you have to be aware of it, when to switch over, how to switch over, and which are the doses which you need to, you should go slow and titrate up. That's important. So the key communication, I would say, you can always, it's very important that you just don't leave with the 3 milligram dosage and try to continue with the same, because that's not going to give you a therapeutic benefit. So obviously you need to explain that the gradual escalation of the dose is important, and we need to increase it from the initial 3 milligram and then check up every 4 weeks. So that would be a much more realistic. You can achieve the requisite endpoints, whether it's weight loss or HbA1c reduction. Along with that, if you look at the occurrence and management of GI side effects, obviously it's the same as for all GLP-1 receptor agonists, injectable or oral, and you have to discuss that with the patient, because otherwise you won't get the compliance and adherence to the molecule. You need to sit with him, counsel the patient to understand. Make him understand what these drugs are and how do they really act, and what could be the side effects of this particular drug. And then they are much better tolerated and the compliance increases. And obviously, pregnancy, breastfeeding contraindicated. Missed doses, you should not take the dose on the same day. You'd rather repeat it on the next day. So these are the key communication of oral semaglutide. And this is how I'm going to end basically. So to summarize, the GLP-1 receptor agonists are among the most effective medications. We all are very much vigilant about HbA1c reduction, the body weight, the composite outcome, and the pill burden. And this one particular molecule will probably be able to address most of the issues. Oral semaglutide obviously is a scientific breakthrough. There's no way we can talk anything else. It is an innovation par excellence, and definitely it will give a convenient oral formulation. Across the global pioneer trials, it has proven its efficacy, achieved HbA1c reduction up to 1.5%, and the weight reduction up to 5 kg. One of the premier molecule, I would say, who could achieve such a great HbA1c reduction along with weight. And they have been found to reduce HbA1c more than the SGLT2 and DPP4 and added to 1 or 2 oral drugs. And therefore, and can always be added to an insulin therapy where the doses of insulin can be reduced. In patients with HbA1c of more than 9%, there is no other molecule which can reduce the HbA1c of more than 2.6%, which we have seen with oral semaglutide, and without the agonizing impact of hypoglycemia. So you can always achieve that with oral semaglutide, and we obviously are waiting for the last SOUL trial to come out with a positive cardiovascular impact. Thank you, friends. Thanks a lot once again. Stop sharing.
Thank you, Dr. Vijay, for lengthy but wonderful talk. And now we are, because of time constraint, we are skipping the questions. Now we are going for the next talk.
Our next talk is by Dr. Sanjeev Phatak, and he is going to talk on innovative insulin. Dr. Sanjeev Phatak is a very senior diabetologist and endocrinologist in Ahmedabad since 25 years. He is the first diabetologist in India to use insulin pump therapy and director of Juvenile Diabetes Association of Ahmedabad. I think everybody knows Dr. Sanjeev Phatak, and I request Dr. Phatak to talk on subject.
Good afternoon, and thank you very much, the moderators, Dr. Sanjay Shah and Dr. Vipul Shah. And at the outset, I would like to thank Dr. Dhruvi and Dr. Vipul Chawda for giving me this opportunity, as well as the office bearers of the AMA, Dr. Mona Ben, Dr. Gadvi Sahib, and Dr. Dhirendra. I am very much aware that I am supposed to speak only for 10 minutes, so I'll try to cut short my presentation. And may I be allowed to share my screen? Is my screen visible?
Yes.
Okay. So I'm going to talk about the innovations that insulin discovery has made in the 100 years. We know that we are celebrating 100th year of insulin discovery. In 1921, it was discovered by Banting Best and Collins and Philip in University of Toronto. And ever since then, insulin has been the mainstay of type 2 diabetes treatment. In type 1, obviously, it is the mandatory thing without which a type 1 diabetic person cannot survive. We know the insulin is secreted in a basal as well as in a bolus manner. Whenever we eat any meal, maybe breakfast, lunch, or dinner, there is a bolus secretion. And round the clock, there is a basal secretion which takes care of the fasting hyperglycemia and the oral glycemia. Now we have different insulins being manufactured to take care of both these aspects which are present physiologically, and the efforts have been to mimic the physiology as far as possible. Initially, there were short-acting insulins, initially bovine, then porcine, and then came the human insulin, and the bovine and porcine insulins are almost forgotten. The human regular insulin, like human Actrapid and human Insulin, they work within 2-3 hours, and they work for 6 hours thereafter, but their physiological secretion or the dosage does not meet the meal, and that's why they lead to postprandial hyperglycemia as well as delayed hypoglycemia. To combat that, 3 rapid-acting analogs were developed: Aspart, Leulicin, and Lispro by different innovator companies. And these were shorter acting compared to the short acting. So that's why they were called rapid acting analogs. And then came the ultra rapid acting insulins, like the ultra rapid acting Aspart, Fiasp, and now the ultra rapid acting Lispro is also going to be into the market. In addition, we have an ultra rapid acting inhaled insulin also we'll talk about. On the other hand, the long-acting insulins like NPH were not long enough to take care of the glycemic parameters for 24 hours. And that's why the long-acting basal analogs were also developed, starting from glargine U100 and then detamir, and then glargine U300, and as well as degludec U100 and U200 now. At the same time, we had pre-mixed analogs, combination of Lispromix in 75-25 manner or 50-50 manner, as well as the aspart mix in 70-30 as well as 50-50 manner. So the insulins which were classified previously according to the species, the classification changed. Now it is human insulin only or the insulin analogs. And in the analogs, there are rapid acting analogs and now very fast acting analogs or ultra rapid acting analogs. In the long acting, we have glargine U100 and U300, detamir as well as degludec, and then there are premix analogs which we already discussed. The conventional insulin therapy was to give insulin twice a day before breakfast, a 50-50 or a 30-70 dose, and a before dinner dose. But that would not suffice as far as the postprandial control was concerned, and also would lead to late evening hypoglycemia or early morning hypoglycemia. So the creation of modern insulins was based upon that to mimic the physiology. The new types of insulin, which we already discussed, included the rapid-acting insulins as well as the long-acting insulins. So the insulins are changing right from they were invented in 1921-22, and now in 2021, we have several other options available to treat our type 2 as well as type 1 diabetic patients. In the rapid-acting analogs also, we have a concentrated insulin so as to take care of the people who need more dose. So to avoid the more dosage or the more volume being injected. At the same time, in the glargine also, we have a U300 pen available as well as the cartridge available, which contains about 450 units per pen. And that's why those who require higher dosage of insulin or those who have high variability can be the candidates for such types of insulin. On the other hand, Novo Nordisk also developed U100 as well as U200 long-acting insulin, which would last for about 42 hours. And that's why taking care of the flexibility issues which were there with the conventional glargine U100 insulin, because the efficacy may not last for more than 20-22 hours, sometimes with glargine U100. So to take care of that, degludec U100 and 200 as well as glargine 300 were developed, which would have effect lasting more than 24 hours, so as to take care of the 2 or 3 hours of the late night or the early morning hyperglycemia, which would otherwise occur in an insulin which is not working for 24 or more than 24 hours. So rapid-acting analogs as well as the long-acting analogs were developed. The key clinical trials of all these insulins showed that they were better than the previous insulins. If you look at the trials of Lispro, Aspart, or glulysin, all these trials showed that the post-breakfast, post-lunch, and post-dinner values were definitely better than the human regular insulins. Hypoglycemia was similar or actually lower, and the late evening effect was much less compared to the human regular insulins. And that's why they became more and more popular, both in type 1 and in type 2 diabetics, but more so in type 1 diabetic. The basic advantage of the rapid-acting analogs was that you would not require to wait for 30 minutes before you eat your meal. As such, also with human regular insulin, hardly anyone waits for 30 minutes, and that's why the peak effect does not come at the end of 2 hours of meal, and that's why you get a significantly high postprandial hyperglycemia. Whereas with the rapid-acting analogs, they work within 1 hour, and so they take care of the postprandial peaks in much better way compared to the human regular insulins. Similarly, in the basal analogs, which are now very, very popular, all of us use, detamir, which is used in pregnancy because it is having pregnancy category B, as compared to the other insulin, basal insulins, which are in the pregnancy category C, including glargine. But otherwise, glargine U100, U300, and U100, as well as U200 of degludec are now in use globally. And in our country, we have glargine U100, U300, as well as degludec 100 available. The longer acting insulins have minimal glycemic variability, and as compared to U100 glargine, you can see that U300 glargine is having even less variability. Similarly, U100 degludec as well as U200 is also having less variability compared to the conventional U100 glargine. And that's why they are becoming now preferred insulin in people having glycemic variability, type 1 diabetic people, or elderly people, or people with cardiovascular disease or brittle diabetes. Amongst the glargine insulins, U300 insulin, as you can see from this slide, has a flatter and more prolonged effect, and that's why it allows for more flexibility also, and less variability is also an advantage of U300 glargine. If you compare the variability of U100 glargine on degludec also, in the switch 2 study, there was a clear-cut reduction of hypoglycemia, both confirmed nocturnal as well as the severe hypoglycemia in the degludec arm compared to the glargine U100 arm. That's why showing the benefit of degludec 100 against U100 of glargine. Based upon the discoveries, the aspart as well as the lispro were also made in combination with the intermediate acting insulin by doing some molecular modification so as to make them twice-a-day insulin, which would suffice in many of our type 2 diabetic patients who would require twice-a-day insulin therapy and may not be the candidates for the basal only or basal bolus therapy. So there is an option of using either a premix analog or even a premix formulation, co-formulation, what we call, of a rapid-acting insulin aspart along with degludec, and which is also giving a very good effect on one of the postprandial as well as the basal, so as to take care of the HbA1c in a better way compared to once-a-day basal insulin. What are the other innovations? We now have an inhaled insulin. Unfortunately, that is not available in India, and in US also it is not very popular. Previously, Pfizer had marketed one of the inhaled insulins, which failed. But now we have an Afrezza insulin, which is I am sorry for the poor quality of this slide, but this is an inhaler insulin which works rapidly and gives rise to much lower postprandial values compared to all other rapid-acting insulins, and maybe a preferable insulin in type 1 diabetic patients, especially when they are going for a party and do not want to inject. This is not yet available in India. It's available in US. Moreover, the combination of GLP-1 along with insulin is also now available. Ideglera is one combination, and soon Iglar-Lixi by Sanofi may also be launched in our country. Additionally, pancreas transplantation, islet transplantation, artificial pancreas, all these are under process of development. But when it will become reality in our country, we'll have only to wait for some more time. The future is in the smart insulins, which is glucose responsive insulin. And they have a binder which binds to insulin when the blood glucose is low, so insulin is not released. And as soon as the blood glucose becomes high, the binder allows the insulin to get released, and that's why it works almost physiologically. It won't work when the glucose is low. It will work only when the glucose is high. The smart insulins may be coming in next 2-3 years if all the trials, especially phase 3 trials, are successful. Oral insulins. Well, we now have a peptide in pill, and insulin is also a peptide with a longer molecular weight than larger molecular weight than GLP-1 analog. Biocon, our own Indian company, Novo, Amylin, all these are in the race, and probably in the next decade or this decade, we'll see some good positive news coming about for the oral insulins as well. So the milestones are not yet reached. Future is definitely bright. The holy grail is still far from being reached, and that's why we'll have to keep innovations on in the insulin therapy. Till that time, we'll have to rely upon the basal as well as the rapid-acting insulins which are available in our market. With this, I would like to stop here. Thank you very much once again, RIMS, for giving me this opportunity. I'll stop sharing.
Information on insulin.
Now we are moving toward the next talk. there is on RSSDI therapeutic wheel. RSSDI Endocrine Society of India Clinical Practice Guideline 2020 caused ripples in the turbulence sea of the diabetes management. It's a unique Indian contribution to the medical science, simplifying the puzzle of choosing the anti-diabetic drugs. RSSDI ESI therapeutic wheel is now recognized the best way to proceed to treat the diabetic patient. And to talk physician at HCA Hospital, Raipur, Ahmedabad since 1987. He is a regular faculty of EMA, APA, RSSDI Diabetes India, and RSSDI Regional Conference. He has delivered lecture at San Francisco. He is an ex-coordinator of Gujarat Medical Journal. He is an ex-president EPA. He is a part of various public awareness program. Presently working on school children's obesity project. Dr. Rudraksha, sir.
Thank you very much. I hope you can see. You can see my screen.
Yeah.
Okay.
Yes, sir.
So I'm not going to talk more than 10 minutes. Certainly, we'll finish within 10 minutes. RSSDI therapeutic will. That is a gift.
So please kindly share your screen.
It's not seen.
No, you have to share your screen, sir.
Screen is
I
seen,
already
but
shared it.
slides are not there.
Can you see the screen?
No, sir, please share the screen. Please share your slides.
I already shared it, but because of my biodata slide, it was.
Just press escape on your.
I know it.
Yes, sir. Now
Yes,
it's
yes.
seen.
Okay. I asked about my shared screen is being seen, and the chairperson said, yes, you can. And I had already shared the screen, but because of my biodata slide, it was stopped. So RSSDI therapeutic will. We are going to talk not more than 10 minutes because it is already 1.5 hours late, as I can see. This is RSSDI therapeutic will. How did it came into the existence? Dr. O.P. Gupta gave RSSDI to India. So that's Dr. O.P. Gupta's contribution to India. And then Gujarat gave the logo to RSSDI, Research Society of Study of Diabetes in India. Gujarat also gave RSSDI therapeutic wheel to the world. And we also gave Dr. Bansi Sabu to India. So there's 3 contributions from India to RSSDI. The wheel was created in a 16 by 16 consulting room of HCG Hospital, Ahmedabad, where myself, Dr. Sanjeev Phatak and Dr. Bansi were there, and few of the ideas were added by Dr. Mahadev Desai. So that's how it started. What was the need for this RSSDI will? It was for easy access to the therapy decision for our primary care physician. We all knew that Indians are different and we needed a different guidelines. So even before USA or ADA came out with certain guidelines, India was first to begin those changes. We knew we are thin fat Indians, more fat and less muscles, and therefore this brief objective of RSSDI wheel was therapy should target pathophysiological defects in type 2 diabetes. Now remember, this was 1 year before ADA posted this statement in its guideline. Treatment should result in clinically meaningful reduction in HbA1c. Reduction in HbA1c should show sustained durability. Treatment should be safe with no hypoglycemia, weight gain, or other adverse events. Treatment should control macro as well as microvascular events and should be acceptable for the patient. The drug choice should be based on patient preferences as well as the presence of various comorbidities and complications. So this was the idea of creating RSSDI will. And all these things were included in ADA guidelines a year later or a couple of years later. And this was the ABCDEFGH approach for diabetes management, where we selected 8 important criteria before deciding the therapy. The first line of therapy was always going to be metformin and lifestyle changes. But then once you have seen a patient having diabetes already on metformin and lifestyle changes, you require to look for these 8 factors: A, B, C, D, E, F, G, H. A is age, B is BMI, C is CKD, chronic kidney disease, D is duration of diabetes, established CVD, financial concern, glycemic status, and hypoglycemia concern. Remember, once again, I am drawing your attention because RSSTI will precede most of the ADA guidelines which were established on these things. And remember, it was only in 2020, 5 years after these guidelines were developed by RSSTI, that ADA included financial concern in their guidelines as the last column. So we should be proud of the thing that we really preceded ADA, and that is how we created the things. So this is RSSTI lifestyle therapeutic will, where we have given numbers. I is insulin, IC is conventional insulin, then IO is insulin analogs, so on and so forth, which you can go through. Because of lack of time, I'm not going to tell. But everything starts with lifestyle management or lifestyle changes. So prescribe lifestyle intervention to all and metformin to all patients who can tolerate it. Identify 3 most important concerns or factors from ABCDEFGH that we feel we should influence our choice on, and then identify the best choice from the will. So that is how you go. I'll just give a couple of examples how simple this is. So let's look at a case scenario number 1. 40 years old male, obese, male software engineer, uncontrolled diabetes for 5 years, smoker, fasting sugar, postprandial, BMI 31, mildly elevated blood pressure, and his lipid levels are there, eGFR is there. This patient has come to you. What did we require before we went on to RSSTI will? Age, it is there. Fasting postprandial levels there. Smoking there. BMI there. We do not know whether he has got established cardiovascular disease or not, but we have got the duration. So we can select any of these 3 parameters: age, duration of diabetes, BMI, and put it in the will. For example, we take the age. Then the will gives you green, yellow, and orange areas. Orange is one you should try to avoid. Green is one you should try to select. So once you know that there are 4 choices that are available at this age, you put BMI. This is how you put age. Now you put BMI into it, right? So BMI is very high, and accordingly you get 4 more choices, and from these common choices are to be selected, and then you can place the 3rd one, that is duration of diabetes, and that is how you can find out the common denominator out of this, and you can start adding that drug to the metformin. So as I told you, just put 3 of the parameters that are available. It could be age, BMI, CKD, it could be age, BMI, duration of diabetes, it could be age, BMI, financial constraint, whatever you want to pick up, put 3 and find out the common denominator out of this. Once we came out with this RSSTI will, a year later, ADA came out with these patient preferences. And you can see very well that most of the things except for life expectancy were there in our RSSTI will. So we should realize that there is biological variability to the responses. Each person with diabetes is unique, and glycemia is only a part of the whole picture. So not creating a protocol that first drug, then second drug, then third drug, which ADA was doing till then. Instead, we came out with selection as per the comorbidities and coexisting situations, and that really worked well, and the whole world ultimately accepted that this is medicine, but not as we know it. This was precision bombing, millimeter accuracy medicine that was created by RSSTI will. I'm very much thankful to Dr. Bansi Sabu for extending that RSSTI will with the help of RSSTI expert committee, and it became a perfect weapon for primary care physicians and diabetologists to utilize. So personalized medicine is an evolving field in which physicians use diagnostic tests to determine which medical treatments will work best for the patient. RSSDI therapeutic will was a first global step towards personalized medicine in diabetes. Remember the word? It was the first global step towards the personalized medicine in diabetes, and I'm very happy to be a part of it. So that's where I'll stop. Thank you, AMA, and thank you, RIMS. Thank you very much.
Useful lecture. Now we are moving to the next talk, last talk.
Next talk is by RIMS own founder, Dr. Dhruvi Asnani and Dr. Vipul Chawda, and they will give information about the D-Connect. I hope all of you now know Dr. Dhruvi and Dr. Vipul. So I request them to say on D-Connect.
Thank you. We've had a wonderful day all through the time, a lot of happening things. D-Connect was our initiative to connect with all the healthcare professionals across Ahmedabad, across Gujarat. We are still in a primary stage of our D-Connect process, and D-Connect stood for Diabetes Connect. What we actually wanted to do was something as in inviting people to become a part of the Rudraksha Institute of Medical Sciences in the format as not everybody has a team support. Not everybody has a nutritionist at hand in the, at the OPD basis. Not everybody has a physiotherapist or a psychological counselor, or not everybody has a medical officer for a 24/7 support of patients for insulin management or for diabetes management or for medication titration, for SMBG. We have patients messaging us incessantly for, through the WhatsApp, "Ki maro sugar atlu chai, what should I do now? I'm eating this, or maybe I'm sick, and what should I do?" So we thought of, during the pandemic, telemedicine became such a craze, and we thought, "Ki apne already use kari raha hai telemedicine. We are already using the media. We are already using the technology. Why not connect it all?" So we were a part of the Stanford team. We were in touch with Dr. David Maas. He used to do the same kind of project like D-Connect for pediatric diabetes. And we tried to replicate it in Ahmedabad during the COVID times to support all the general practitioners around our Rudraksha multi-speciality hospital by providing them the support of our team, of our pharmacy, of our nutritionist, and of our medical officer, and our consultants as well, not just for diabetes, but also for internal medicine, general medicine, also for gynecology, and also for all the laboratory and diagnostic facility. We have our own ambulance, which is like a mobile van with all the facilities wherein the first aid kit is there. There is a medical officer at hand, and we have an ECG machine. All the vital parameters can be checked in the van, and it is moving around. What we used to do is we used to move it from one village to another, and we had identified 5 centers at that point of time during COVID, and our team would go to that place, to that particular general practitioner, and we would help them with screening for non-communicable diseases, and we would help them with any kind of acute conditions if they needed any backup support. We had a backhand team at Rudraksha Hospital. All the consultants were there, and they were at the disposal for the medical officer as well as for that general practitioner. And through telemedicine, what we did, we also conducted CMEs. So if there were any tough cases that the doctors wanted to discuss, we would meet once in a week basis, and we invited them to discuss, "Okay, these are the problems that we are facing," and we would help them resolve the case. And the patient primarily remains of the primary doctor only. We were just backhand support for the general practitioner, and we were trying to provide him or her with the necessary facilities that COVID pandemic hampered from providing it to the general practitioner. And thus came the idea of D-Connect, and it is an award-winning idea. We applied to Diabetes India team, and we said we could replicate it more. We are doing it at 5 centers across Ahmedabad. So we'll tell us more about the logistics issues involved with it. And we want to replicate it into 5 more centers, and we invite every healthcare professional, not just for the sake of Diabetes Connect, but we can associate further on the other faculties and other specialties as well. And with that, we are here to congratulate Dr. Vipul Chawda for winning the award for the Connect initiative. And would you like to say something for that?
Diabetes is a growing demon, and our country is having big trouble because of diabetes, because we are at a high risk of diabetes. Our populations are very prone to develop diabetes as well as its complications. So RIMS is trying to work in that direction, that in near future, in upcoming decade or two, India should not face much problem. Our population remain healthy. Preventive medicine that we are working towards, and we require support of all medical fraternity, all pharma fraternity, all those who are associated with the medical field to work hard, and Deconnect is a first step towards that. Thank you. So with this, we end our fourth and last session. And for facilitation of chairperson, I would ask Mr. Hiren Patel sir to come on the stage. Dr. Vipul Shah sir, we all know him for more than a decade. And Dr. Sanjay sir, we also know him for more than a decade for their work in the medicine and infection disease. Thank you, sir. Hiren sir, Sanjay sir ne bhi aap facilitate. Hiren sir is very dynamic and revolving personality. Is a good friend of mine. Thank you, sir. Thank you, Sanjay sir. Thank you, Vipul sir.
Thank you to all our faculties and delegates who've joined us online virtually. Thank you to everyone present here physically, despite all the rains being a Sunday. Thank you for sparing your time for us. Thank you all the chairpersons. Thank you for chairing the session fantastically. We still have Jayaprakash Singh sir. Thank you, sir, for connecting with us. And with that, I think we can end. And I thank once again to all the audience present. Thank you. Thank you so much for bearing with us. Oh, we'll have a small 1 minute. We'll have a national anthem before we leave. Thank you to the RX team.
So I invite all the RX team and
RIMS team
on the stage.
जय जनगण अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jay. We also have a prize distribution. We have the chairpersons here. Manapelu, naam aapne bata.